Appropriate ADH production. Everybody get it? Whenever we are dehydrated, the plasma osmolarity will increase. Increased plasma osmolarity will go to the pituitary and make the posterior pituitary to produce antidiuretic hormone. That in turn will come and cause diuresis from happening and lead to water retention. There are channels called aquaporin channels which are being opened up by this antidiuretic hormone, which will cause the water to get reabsorbed in the collecting duct. That defines the appropriate ADH. Inappropriate का मतलब क्या है? Though I am not dehydrated, though I am well hydrated, even though my plasma osmolarity is normal, though I don't have any hyperosmolarity, ADH is produced meaninglessly, which is called inappropriate, thank you Suresh, ADH production. So what will happen when the SiADH is there? There is no ADH. There is ADH excessive. So that is the reason there is an excessive water retention. And all that water which is being retained, what will it do? Whatever the water that is being retained by the tubules will go into plasma. That causes an increased plasma volume. That increased plasma volume will cause the stretching of the atria. And the stretched out atria will produce atrial natriuretic peptide. That natriuretic peptide will come to the glomerulus and proximal tubule and causes sodium lost into urine. And the net effect is losing the sodium into urine. And that leads to hyponatremia. So a lot of people think hyponatremia is because of water retention will dilute the sodium. No. That is not the cause. The hyponatremia is because of absolute loss of the sodium into the urine because of the production of the atrial natriuretic peptide by the distended atria because of the retained plasma water leading to increased plasma volume. So the fundamental definition of SiADH is urinary sodium more than 20 milliequivalents. And what will happen to serum sodium? It will decrease, that is presence of hyponatremia. What will happen to the urine osmolarity? Urine osmolarity increase because it becomes no water inside the urine, no, it is all recovered. And plasma osmolarity decrease. So what are the four parameters defining SiADH, doctor? Hyponatremia, decreased plasma osmolarity, increased urine osmolarity, increased urinary sodium more than 20 milliequivalents defines SiADH. And a patient of SiADH should not be in a dehydrated condition. If it is dehydrated, it is not SiADH, it is ADH only. I mean, appropriate ADH production only. Second, there should not be any ascites, there should not be any pedal edema, there should not be any edematous state. If there is an edematous state, what will happen? All the water is going into extravascular space in the form of edema. That decreases the plasma volume. A decreased plasma volume will have a higher osmolarity and that naturally stimulates the ADH. That's the reason there should not be dehydration, there should not be hypervolemia, there should not be an edema In such an individual who is euvolemic, the presence of hyponatremia with increased urinary sodium, with decreased plasma osmolarity and an increased urine osmolarity defines SADH. Okay? SADH is a diagnosis of exclusion. What is the meaning? There should not be any thyroid dysfunction. Because thyroid dysfunction like hypothyroidism lead to myxedema. Myxedema also can stimulate ADH appropriately. But we want the inappropriate ADH stimulation. There should not be any thyroid disease, no liver disease, no cardiac disease, no adrenal disease. Suppose if there's any cardiac disease, there's a congestive heart failure, there will be pleural effusion, there will be ascites that can appropriately stimulate ADH production. If there is any renal disease can lead to development of proteinuria, nephrotic syndrome, edema, that can appropriately stimulate ADH production. That's the reason SADH is called diagnosis of exclusion, where there is no cardiac disease, no adrenal disease, no thyroid disease, no renal disease. In a euvolemic individual, the presence of hyponatremia with an increased urinary sodium, with a decreased plasma osmolarity, with an increased urine osmolarity defines SADH. Now, ये जो SADH, why pituitary inappropriately producing the ADH? kaiku product प्रोड्यूस कर रहा है ऐसा, कारण क्या है? Manu, can you please ask Mary to post in all groups the link? कारण क्या है? Generally, any lung disease like lung carcinoma can cause SADH. Certain drugs like SSRIs, selective serotonin reuptake inhibitors. Why are we depressed? We are depressed because of the low serotonin. Why are we happy? Because of high serotonin. Why Google search is addictive? Why Instagram ting 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 ting? Huh? Why do we do that? Because every video makes our serotonin rise. So rise of serotonin will make happiness. Serotonin need PG classes like cerebellum and marrow. Yesterday was alphabet. Alphabet is also a very good name to start classes. So, serotonin. High serotonin will lead to happiness. That's the reason whenever we have depression, we use fluoxetine, duloxetine. All these are what? SSRIs. Whenever we are having a severe pain because of the neuropathy, we give 20 milligram, 30 milligram, 10 milligram duloxetine. Dumenta is the brand. That is because serotonin will bring better pain tolerance. So in day in and day out clinical practice, we use SSRIs very frequently. Somebody has an obsessive, compulsive, neurotic OCD and plucking the hairs, trichotillomania, washing the hands until there are ulcers. Such people, to overcome, what will you give? SSRIs. But SSRIs can inappropriately stimulate carbamazepine, cyclophosphamide, the two other drugs which can lead to SADH. Then any head trauma, cerebrovascular accident, stroke patients, you get SADH. Right? So every day in clinical practice we have. My daddy is 74-year-old, sir. He has a meningioma operated recently, sir. He is having altered sensorium, पहचान नहीं पा रहे क्योंकि उनका सोडियम गिर गए सर. काइको meningioma, post neurosurgery, post cerebrovascular accident, patients will develop SADH and land in hyponatremia with an altered sensorium. Understand? So, how do you treat the SADH? Just because hyponatremia is there, bolke, you may have a tendency to give normal saline, but you should not give normal saline in a patient of SADH. Why? थोड़ा हम नॉर्मल एबनॉर्मल सलाइन के बारे में बात करेंगे. थोड़ा कैलकुलेशंस आपके बाय हार्ट रहना. इफ यू आर मुरली भरद्वाज का गैंग है तो नॉर्मल सलाइन बॉटल जो मिलता है आपको बाजार में, उसमें 1 लीटर में 154 मिली इक्विवेलेंट्स ऑफ सोडियम मिलता. Let us say, what is my normal sodium value? 135 to 140. So suppose my sodium गिर गया 125 milli equivalents. So deficit कितना है? 10 milli equivalents per liter. Liter of what? My ECF. 10 milli equivalents per liter of my plasma. ECF. So, how much is the total body water in a 70 kg person or any person? Always 60% is total body water. So 70 kgs आदमी बोले तो 42 liters वाटर कैन है. हम सोचते हैं हम शेर खान हैं. नहीं, शेर खान नहीं, हम एक्वाफीना बिस्लरी है. That's the reason if the person goes for 10 times loose motions, even if he is chief minister of Andhra Pradesh or prime minister, shrunken, right? So typically 60% of the body weight is water. That means 70 kgs individual is 42 liters of water. So for each liter, if I have to increase the sodium by 10 milliequivalents, 42 liters का कितना डेफिसिट है सोडियम का? 42 into 10 milliequivalents is equal to 420 milliequivalents. अगर मैं नॉर्मल सलाइन को रिप्लेनिश करने के लिए सोडियम रिप्लेनिश करने वाला फ्लूइड बोल के डिसाइड करे तो कितना लीटर देना पड़ता? 154 per liter. I have to replenish 420. That means I need to give 3 liters. Each normal saline bottle 500 ml समझो, पकड़ो. तो कितना liters? I need to give 3 liters. 6 normal saline bottle चढ़ाना पड़ता. My entire blood volume is 5 liters. Into that, if I give 3 liters of normal saline, I'll get pulmonary edema and die. So, to improve the sodium, it is not a scenario. Why? One more reason why you can't do that in a patient who is having SIDH. He is euvolemic. मतलब already उनके body में 5 liters of blood है. Because of this inappropriate ADH, water is retained. On the top of it, you want to add 3 liters of normal saline, बोले तो you will die. That's the reason हम normal saline इस्तेमाल नहीं कर सकते, मगर abnormal saline लेना पड़ेगा. तो abnormal saline क्या होता है? There is no abnormal saline. Don't give those answers to the examiner. He'll faint. 3% NaCl, which is called hypertonic saline. Hypertonic saline का calculation क्या है? 1 liter of hypertonic saline has 514 milliequivalents. 154 बन गया 514. Then for you to give 420 means 750 ml slowly is more than enough. Another important rule about correcting hyponatremia, never collect the hyponatremia more than 8 milliequivalents per liter per day. मतलब 130 वालों को 120 वालों को 128 बनाना फर्स्ट डे, देन 128 से कहाँ जाना 134, 6 milliequivalents next day, but not 132, 120 to 134, no. So maximum 8 milliequivalents. Suppose if the person's body weight is 70 kgs, 70 kgs, 70 kgs में how much is the water? 42 liters. 8 milliequivalents means 42 into 8. 8 for the 30, 8 to the 16. 336 milliequivalents. 336 milliequivalents means 514 is 1 liter bole to 3% saline. 336 will be somewhere 600 ml. 600 ml is what you can give. 3% NaCl slowly over 24 hours. You go to your ward nurse and ask, एक 600 ml 24 hours में जाना है तो per hour 600 by 24 रखना, speed, drip rate, कितना माइक्रो ड्रॉप्स जाना पड़ेगा बोल के पूछना. Few things best learned from the ward nurse. Senior ward nurse is better than junior doctor. Okay? Suppose if you run very fast sodium, what will happen? It will lead to CPM. Central pontine myelinolysis. Very good to listen that answer. We discussed it in neurology, right? Yes, no? Please come. CPM. Pons is the center of differentiation. All motor activity in our body will go through pons. The moment the pons is demyelinated, hata nahi utega, pama nahi utega. You'll be lying down like a frog on the bed. Pons is the center of horizontal gaze. Gita went here, Gita came here, Gita went there, Gita came here. You are watching at Gita in the reading room. Horizontal gaze, right? Ultimately, you went and proposed with Gita. Then what Gita said? क्या रे कभी आईना में चेहरा देखा क्या? So that is what vertical gaze. Vertical gaze is decided by midbrain, which is at higher level. Horizontal gaze is controlled by pons. If the pons is demyelinated, still midbrain is working. That's the reason patient with central pontine myelinolysis will be lying down like a frog with no horizontal gaze. The only motor activity is capable is moving the eye up and down, which is like a frog. It's called frog-like locked up position. Locked up syndrome is the name given to central pontine myelinolysis. Clear? If you correct the sodium drastically, understand? So, summarize once more. SADH is a diagnosis of hyponatremia in a euvolemic individual without renal disease, without thyroid disease, without adrenal disease, without liver disease, who has got hyponatremia with increased urinary sodium, with low plasma osmolarity, with high urine osmolarity. This story. Then how do you treat SADH? One is you will try to fill that sodium deficit hyponatremia by giving hypertonic saline. Then we give ADH antagonistic drugs. What is a very common drug that we give? Tolvaptan. What is that? Tolvaptan. Tolvaptan is available as common brand that we use every day is NAT rice. NAT means sodium, rice, increase. 15 milligrams twice daily. Okay? Very common everyday stroke patients will show hyponatremia. Alzheimer's disease patients show hyponatremia. Depression patients show hyponatremia. Why? Depression में SSRIs use करते हैं. SSRIs are antidepressants. SSRIs can lead to development of SADH. Okay? So tolvaptan. Finish. That's all that you need to know about SADH. Etiological factors, carbamazepine, SSRI, cyclophosphamide among the drugs. And ectopic ADH production by small cell lung cancer. Stroke and CNS disorder patients also will have. Tolvaptan is the treatment. And what is the clinical definition of SADH? These things you should remember. Next comes primary polydipsia. Polydipsia वाले पानी पीते 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 वो सोचते हैं कि हम पानी पिए तो तंदुरुस्त हो जाएंगे. Many disorders are psychological. So there's an excessive water intake. It can be psychiatric illness, it can be any hypothalamic lesion affecting the thirst center. You know the various hypothalamic nuclei? Ventral hypothalamic nuclei, dorsal hypothalamic nuclei, lateral hypothalamic nuclei, what is their individual function? वो सब karma, we will have it in physiology revision when you come for NEET PG. Now your medicine exam going, no? Hypothalamus में उच्च nucleus क्या करेगा वो सब पढ़ने का time नहीं है. Right? So next, how will be, because of the continuous drinking of water, the serum osmolarity will be diluted and that's the reason it will decrease. How is their ADH levels? All that water will go and cause the decreased osmolarity will suppress the, always hyperosmolarity stimulates ADH, hypoosmolarity suppress the ADH. But what is SADH? In spite of a normal osmolarity, there is a release of ADH is called inappropriate. So what will you tell this guy? Pani peena band karo is what you need to tell. And what all the water that he is drinking, if there is suppressing ADH. If ADH is not there, diuresis will be there. Antidiuretic hormone is not there, diuresis will be there. So all that water will go into urine. Right? So water restriction is considered to be the treatment. Okay? Then comes diabetes insipidus. What is the meaning of it? ADH is not produced by posterior pituitary, or ADH is produced but it is not acting on the collecting duct in the kidney. Accordingly, you have a central diabetes insipidus and nephrogenic diabetes insipidus. So central diabetes insipidus का कारण क्या होता है? Why pituitary stopped? Idiopathic. We doctors are idiots. Then comes brain injury, like trauma, hypoxia, tumor, brain surgery, infiltrative disease. So remember, brain injury can cause both inappropriate ADH secretion and also no secretion of ADH. दोनों हो सकता. Then any diabetes insipidus में क्या होता? If ADH is not produced, there is too much of diuresis. Hence serum osmolarity become increased. Obviously, no. If all water gone into urine, serum osmolarity become hyperosmolar, increased. And ADH levels are low. That is the central diabetes insipidus. There is no role for water restriction in case of diabetes insipidus. Water restriction has a role in primary polydipsia. Then how do you treat? You need to give an analog of ADH, which is desmopressin, need to be administered. And whenever you give desmopressin, what will happen? once more the urine osmolarity will restore. Then it means that it is the absence of ADH responsible. The next is called what? Nephrogenic diabetes insipidus, where ADH is produced by pituitary, but it is not able to go and act on the collecting duct. Aquaporin channels are now more opening when ADH asks it to open. That is, there is a collecting duct level resistance. So, why will that happen? Few people it is hereditary because ADH receptor is having a mutation. Then certain drugs, lithium demiclocycline are the two drugs which can lead to ADH resistance at the collecting duct to retain water. Lithium and demiclocycline. Whereas SSRIs lead to inappropriate ADH production, lithium demiclocycline lead to ADH resistance at the kidney to act. Opposite. Don't forget, favorite question in the entrance exam. Then two dyslipidemias, hypercalcemia, hypokalemia, both of them will create a resistance to the action of ADH on kidney, on the collecting duct. That's the reason those who have hypercalcemia, what is their clinical presentation? ADH doesn't work. There is no antidiuresis, means there is diuresis. Hence, polyuria, polydipsia is the presenting feature of hypercalcemia. Please don't forget. Hypercalcemia hai to they present with polyuria. Why? Because hypercalcemia will go and creating ADH resistance to act on the collecting duct, leading to nephrogenic diabetes insipidus, leading to polyuria. So also hypokalemia. When the person is losing all the water into urine, his serum osmolarity will increase. And in these patients, it is not an absolute deficiency of ADH. ADH is produced by pituitary, but it is not acting on kidney. That's the reason ADH level is normal or increased. Normal or increased state, but not decreased. Then water restriction has no effect. Desmopressin also don't have effect. Exogenously, if you give desmopressin, also no effect. Because endogenous desmopressin only has no effect. Exogenous desmopressin ko kya rehta? Nahi rehta. Then how do you treat? In them, we give hydrochlorothiazide, we give amiloride and indomethacin. What is funny thing about it? Thiazide is a diuretic. And diabetes insipidus is a diuretic state. Diuretic state में patient को diuretic kaiku दे रहे. Professor Mubin will not agree with that. But I'll tell why. Did you understand the situation? Antidiuretic hormone is not acting on the kidney means aquaporin channels are not able to retain water, means water is lost into urine. Hence, it is a diuretic state, diabetes insipidus. There is a polyuria. In that, we are giving a thiazide, which is itself a diuretic. Why do we do that? Why do we give thiazide to treat? What is the logic behind it? So, you are having what? Glomerulus, Bowman's capsule, descending limb of loop of Henle, and finally here collecting duct, and here you have the aquaporin channel. ADH will come and open it and then reabsorb the water. But here ADH is resistant. So water is not reabsorbed in collecting duct. Okay? Now, first of all, we should understand how is water reabsorbed. 85% of the water is reabsorbed in proximal kernel tubule. The contribution of the distal collecting duct is only 15%. So the distal collecting duct is like a drunken daddy. अब्बा शराबी है, दुनिया वालों माफ करा, मैं नशे में हूं. इज अ ड्रंकर्ड. अगर अब्बा ड्रंकर्ड है तो परिवार को कौन बचाएगा? अम्मी जान. वो जाके डबल ड्यूटी करेगा, मॉर्निंग ड्यूटी, इवनिंग ड्यूटी, राइट, एंड समहाउ सेव द फैमिली. इसलिए चींटी जैसे मां, हाथी जैसे बाप से भी ताकत ज्यादा रहता to save the children. So when distal kernel tubule is not working or collecting duct is not working, the मां कौन होता है? Proximal kernel tubule. तो पूरा बदन पूछेगा, मां धूप लग रही है, पानी जा रहा है पेशाब में, क्योंकि बापूजी ने वाटर रिटेन नहीं कर रहे. तो मां क्या करेगा? It has the ability to absorb all 100% water in proximal kernel tubule only. So that बाप काम करे या नहीं करे, मां पूरा पानी को reabsorb करके it will take care that the person is not dehydrated. मगर मां को कोई जगाना पड़ता. Somebody need to wake up the proximal kernel tubule and tell that, अरे पिच्ची PCT, DCT is not, sorry, collecting duct is not reabsorbing water बोल के इसका आंखों को खोलना पड़ता. So how will proximal kernel tubule will be woken up and then be told that the collecting duct is not working and water is lost into urine? Proximal kernel tubule has a mechanism. Whenever the glomerular filtrate is sluggish in flow, then it will understand this person is dehydrated. Because a dehydrated person with a low plasma volume will have a low renal plasma flow, will lead to low afferent arterial pressure, leading to low GFR, leading to low flow of tubular fluid. So, we want to create that situation to wake up the proximal kernel tubule. Hence, what we do, we give a powerful diuretic which is called thiazide. So, giving thiazide, what it will do? It will cause significant fall of the plasma volume. That decreases the renal plasma flow. That will make the tubular fluid sluggish. And immediately there is upregulation of the proximal kernel tubule to reabsorb all the 100% water. And even if the collecting duct is not working, still the proximal tubule is able to reabsorb entire water. That is the funda behind giving thiazide. Your examiner will suffocate. He don't know all these things. He only buttified with thiazide as he used it in. First of all, MD General Medicine seeing diabetes insipidus, diagnosing it and treating it itself is rare. MD General Medicine treating SADH is common. वे MD General Medicine के बाद वो कभी भी SADH नहीं देखा बोले तो वो A category या C category, what is it? He is C category, Mercedes C. C class. A class, B class will definitely C before they become assistant professors. So don't worry. So the good news of the modern time is many of your examiners are all recently passed from the private colleges only. That's the reason they don't have much exposure. Unlike the old-time examiners who used to, pathetic. Just because he knows apex can be felt, he wants you also to feel the apex and tell. Otherwise, he won't be happy and fail exam and go. Now, so doctor, you got it right? Are we clear? Now, how do we make a diagnosis of diabetes insipidus? We do a water restriction. No water is taken for 2 to 3 hours, followed by measurement of urine volume and osmolarity and sodium concentration. So what will happen? If you do water restriction in a normal person, what will happen? He become dehydrated, plasma osmolarity increases, that stimulates ADH production. ADH will cause antidiuresis. Antidiuresis will cause no water into urine. Hence, urine osmolarity will increase to more than 600. So, what is the effect of water restriction in a normal person? Urine osmolarity will become increased. But a patient of diabetes, central diabetes insipidus or nephrogenic diabetes insipidus, in spite of water restriction, his urine osmolarity remain low because ADH is not working and he is continuously having diuresis. Whereas in a primary polydipsia patient may, if you water restrict him, the whole problem of primary polydipsia is drinking excessive water. Unko water band kare to problem solved. So just like a normal person, even primary polydipsia patients' urine osmolarity also will increase to more than 600. Are you all clear to this? Huh? Consult professor for a revision. Huh? Now, what is the response to desmopressin? If you give desmopressin and water restrict, if it is a central diabetes insipidus, urine osmolarity will improve, but not in case of nephrogenic diabetes insipidus. So, what is endocrinology? Endocrinology, I say, endocrinology is like our daddies, or not daddies, like our aunts. You know, aunts are very critical in our life. I just studied to impress my paternal aunt, Menata, because I used to have a crush on her daughter, but she's a city girl and I is a country boy. And my aunt used to feel, unless you are a doctor, unless you are a level, then only you can talk to my daughter. So just to impress her, I used to do physics, chemistry, read a lot. Later on, I felt there are much more beautiful faces in the college than my aunt's daughter. But ultimately, the inspiration had been my aunt's daughter. Right? So why did we come to aunt and daughter? Endocrinologists are like that. If there is a hypofunctioning gland, hypofunctioning endocrine gland, what will they do? They will do a stimulation test. Stimulate kare to normal gland should produce. Hypofunctioning gland does not produce. जो इडियट है उसको इडियट बोल के प्रूव करने के लिए उसको क्या करना पड़ता, चैलेंज करना पड़ता. Get medicine seat, then only you can look at my daughter, right? Then hyper functioning gland है बोल के प्रूव करने के लिए क्या करते हैं? Suppose adrenal gland is hyper functioning, producing excessive steroid. What will they do? Suppression test. Right? A arrogant kid hai to what will they do? They try to suppress. But an arrogant kid never gets suppressed. That is the job what our seniors do in medical college. Gaitan pad rahe kya? Oh man, do you know? Last year that fellow studied Gaitan and failed. That's how the deterioration begins. Otherwise, all of us want to read Guyton, Gray, Harper, Goodman, Gilman, but our seniors will come and do dexamethasone suppression test and bring down hyperfunctionality in our mind. So we are all brilliant, but for our seniors in medical college. अगर वो नहीं है तो हम कितना ऊपर गया होगा, right? So doctor, stimulation tests are to prove hypofunctionality, suppression tests are to prove hyperfunctionality in endocrinology. Clear? Now, let's talk hypothyroidism. This all of you know. Hypothyroidism presents very vaguely. Hair loss, doctor. A college girl comes with hair loss. The cause is hypothyroidism. A lot of people who are hypothyroid don't know that they are hypothyroid. Until you find it high TSH and treat them, then they will come and say, Abba, there's a different life, doctor. There are few addictions like alcoholism, etc. Are such a habits that until you break them, you don't know that what kind of person inside you killed them. Understand? Overeating pizzas and all that. You stop for about 1 month, the temptation, you're a different person. Instead of taking 3 times meal, take only 2 times meal. You're a different person. You're lightweighted suddenly. But you need to have that will. Hypothyroidism is also a condition where the person of myxedema will be so drowsy. TSH levels will be touching. Normal value is 3 to 5. TSH will be touching almost 120, 110. I'm having one patient. Next time I'll post the video. Just as he walking into the OP, I know that it is hypothyroidism. He comes from Medak. He came 4 days to the OP and missed my appointment. Finally, I was just getting down the steps. Aake pakadke, sir, koncham chudandi sir, nanu mee appointment dortaledu, he said. I said, arre, chudangane is like a god for me. Come, I took a video. I said, get a TSH order, 120. Right? He was brought by his brother-in-law. So, after giving 125 micrograms, equivalent to his TSH level, thyroxine, is completely a changed person. Next time I could not recognize when he came to OPD. Whole Medak patients he will bring regularly. Right? So, so what I'm saying you is, hypothyroidism is like that. It can lead to constipation, decreased appetite. Hypothyroidism can lead to myopathy with proximal muscle weakness with the raised CPK levels. Carpal tunnel syndrome in Sister Mary in the ward with that butterfly, what is that? Masala dosha cap. Sister Mary, she will have carpal tunnel syndrome with a hoarse voice. Doctor garu, it chahiye ra, poddun levangane kashanga undi doctor garu. Ammo, TSH kare to 150 rehta. Oh, correct karne ke baad hoarseness gone. Masala dosha cap gone. She became thinner. She became active. Abba, doctor garu, enta beautiful treatment andi. So, that is hypothyroidism. And if you do the deep tendon reflexes, typically there will be delayed DTR, slow relaxing DTR, and hypothyroidism when severe can lead to development of the bradycardia, dyspnea on exertion, decreased cardiac output, etc., etc. So obviously, increased TSH with a decreased free T3 and T4 is diagnostic of hypothyroidism. Hypothyroidism can also lead to hypercholesterolemia because of the decreased LDL receptor expression, is what you need to remember. So that's the reason a patient for a long period of time when hypothyroidism is not treated will end up in coronary artery disease and will die with stroke. That's very important. Okay. So what are the benchmarks I told you last time? LDL cholesterol should be kept less than 70. 20-30 hai to mast. Triglyceride should be kept less than 150. HbA1c should be kept less than 7. These are all the benchmarks that one need to maintain. Okay, so this is the typical puffiness of the face, myxedematous changes, pretibial myxedema it is called as, and the severe bradycardia that you see on the ECG, etc., etc. So what is cretinism? Congenital hypothyroidism is called cretinism. It can be because of thyroid gland dysgenesis, agenesis, hypoplasia, ectopic thyroids, etc., etc. And also it can be because of the mutations in thyroid peroxidase enzyme, which is required for converting tyrosine into triiodothyronine. Typically, these cretins will be pot-bellied, puffy-faced, protruding umbilicus, protruding tongue, with a poor brain development in pediatrics. Also, thyroxine is required for the epiphyseal maturation. So, epiphyseal dysgenesis with the growth retardation is also the feature of hypothyroidism. And there is a condition called Kocher-Debris Semilangi syndrome. ఎప్పుడైనా విన్నావా? మీ పేరేంటి డాక్టర్ గారు? మర్చిపోయాను. ఉజ్వల ఉజ్వల ఎప్పుడైనా విన్నావా ఈ కండిషన్? మన మహబూబ్ నగర్లో ఎప్పుడైనా చెప్పుకున్నారా? Kocher, बोलो बेटा, Kocher-Debris Semilangi. Right? Kocher-Debris Semilangi syndrome. One of favorite NEET PG questions. मगर एग्जामिनर को मना को बोलना, वो सोचेगा कि तू गालियां दे रहे हो. Kocher-Debris Semilangi syndrome means what? There's a large goiter, short stature, and if you give thyroxine, very good response, and you can see calf muscle will show hypertrophy. Calf muscle will show hypertrophy in Kocher-Debris Semilangi syndrome, along with a goiter, is what you need to remember. Untreated congenital hypothyroidism. This is an 80-year-old child with an endemic iodine deficiency leading to goiter. This is macroglossia, coarse, sparse hair with a delayed closure of anther fontanelle, is what you need to remember. Now, what leads to hypothyroidism generally? Iodine deficiency is most common cause worldwide. Then, even if iodine is excessive also, it can have a blocking effect on peroxidase enzyme, leading to organification of the tyrosine doesn't occur, leading to hypothyroidism. That's called Wolff-Chaikov's effect. Similarly, emidaron patients, where do you give emidaron? Atrial fibrillation. Cardron. Emidaron for a long period of time, if you give, there will be at least 6 side effects of emidaron. Emidaron lead to hypo and hyperthyroidism. Emidaron lead to corneal microdeposits. What are they called as? Verticillate keratopathy. Verticillate keratopathy. Emidaron can lead to pulmonary fibrosis, leading to restrictive lung disease. That's the reason, as a cardiologist, before you start emidaron, you need to get a pulmonary function test, because already patient is a smoker, means he will have some bad lung. Later on, he'll come and sue you in the court of law saying, your emidaron led to my bad lungs. No way. Already I got a pulmonary function test. Right? Then, but one very important thing, you need to explain all 6 side effects to the patient. If you don't do, sued, litigation. Similarly, cyclophosphamide, whenever you are giving to SLE patient or anybody as an immunosuppressant, it leads to gonadal toxicity. So if she's a woman expecting the future children, you did not tell and cyclophosphamide you gave and later she had a gonadal toxicity, she'll come and take your children. Be careful. Gonadal toxicity of cyclophosphamide, known toxicities they are all. We all use doxorubicin to treat breast carcinoma. But doxorubicin, adriamycin taking patients should be told that it can lead to cardiomyopathy. Otherwise they will say, you bloody oncologist and your wife cardiologist दोनों मिलकर scam कर रहे बोल के, क्योंकि बाद में कार्डियोमायोपैथी आए तो आपके बीबी के पास जाएगा. So you'll remember, right? Adriamycin, cardiotoxicity. Cyclophosphamide, gonadal toxicity. Amiodarone can lead to, come on, फटाफट बोलो बेटे. Corneal microdeposits, vortex keratopathy, skin pigmentation. It can cause both hypo and also hyperthyroidism. Both the things are possible. Favorite question. Option A hyperthyroidism, option B hyperthyroidism. आप YouTube में बोलते ना strategy for elimination, वहाँ use करे तो गया, क्योंकि because it will cause both of them. Right? Then there is an entity called euthyroid sick syndrome. Means whenever there is any acute illness also, thyroid binds with thyroid binding globulin. Its levels will get altered, thyroid binding globulin. That's the reason it can cause hypothyroidism, which is called euthyroid sick syndrome. Right? That is, there's a decreased T3 with a normal or decreased T4 and a normal TSH in a critically ill patient is called euthyroid sick syndrome. Finish. That is hypothyroidism. Endocrinal hypothyroidism कोई teach करने का topic है क्या? नहीं. That's the reason I removed acromegaly. You can read. We had been reading acromegaly from 8th class CBSE biology test. Some topics are common, I think you know, no? 8th class ko or DM ko. Common topics रहता. Hyperthyroidism. Opposite, heat intolerance, increased sweating, weight loss. I have one patient, only weight loss. Everybody evaluated for cancer. Nobody did TSH. You'll be very lucky to get such patients, you know. You are called Einstein in general medicine. But actually, Einstein's nahi rehta general medicine mein. My professor used to say, Murli, you won't get Nobel Prize. At least you will get an Oscar award in general medicine, which is done for acting like an intelligent doctor. Right? So hyperthyroidism is what? Heat intolerance, increased sweating, weight loss. There'll be warm, moist skin. If you have a hyperthyroid girlfriend, the first handshake will make you know that she is too warm for you. Right? So warm, moist skin, because thyroxine lead to vasodilation. Hair become very fine. Nails become broken, onycholysis. Pretibial myxedema will be found in Graves' disease. So myxedema is what you generally find in hypothyroidism, but pretibial myxedema unique for Graves. Graves is a state of hyperthyroidism, not hypo. Suppose if it is Graves, then there will be ocular change, ophthalmic changes. What are they? Periorbital edema, exophthalmos. And excess thyroxine, what it will lead to? Sympathetic overactivity. That sympathetic overactivity, what will it lead to? If there is a Horner syndrome, what do you get? Ptosis, anophthalmos. Horner is due to deficiency of sympathetic system. Then opposite will happen in sympathetic excessive. There will be proptosis and lid lag. That is, lid instead of drooping, it will be lagging behind. So lid lag, lid retraction is a feature of increased sympathetic stimulation of the levator palpebrae superioris and superior tarsal muscle. Then there will be opposite to constipation, hyperdefecation, diarrhea due to increased GI motility. There's an increased appetite of voraciously eating but losing the weight, characteristic feature. And excess thyroxine will lead to thyrotoxic myopathy. It's called as, it also leads to proximal weakness, just like hypothyroidism. Hyperthyroidism also lead to thyrotoxic myopathy. But main difference is hypothyroid myopathy may CPK levels increase, but hyperthyroid myopathy may CPK levels are normal, which is a differentiator. And in the Asian population who have hyperthyroidism, there will be severe osteoporosis. I have one Bengali patient, Makarandam. DEXA scan करे तो his bone density is -4 standard deviations. But his age is only 48. 48 males may getting osteoporosis is not expected. So always what is good clinical practice? You expect certain things when the observation the patient is beyond your, in contradiction to what you expected, then you need to think what could be the cause and then you will find the diagnosis. The disproportion between your expectations and the patient's clinical findings is the source for becoming the Sherlock Holmes in clinical medicine. Understand? Suppose a girl, no menorrhagia, and you found significant anemia, only 4, 5 is there. Then when you have checked, MCV is not diminished, then what will you think? No menorrhagia, no blood loss. So this is not unlikely to be blood loss anemia. MCV is normal, that means it is unlikely to be iron deficiency anemia. Possibly what could be the cause for her significant loss of hemoglobin? Maybe is it hemolytic anemia? Then your eyes will look for retic count and then you will find a high retic count. That's how a diagnosis will be made. That's the reason, listen story, listen full story. Let them tell. You also ask what all the questions. That's the reason asking questions is the first step to become a good doctor. And listening the story is the second important thing. But thyrotoxicosis can lead to myopathy, osteoporosis, increased fracture rate. And that patient, I told you, right? TSH levels are not detectable. Such a significant thyrotoxicosis is there in my patient who had a -4 standard deviations of osteoporosis. DEXA scan में you have a T score, Z score. T score क्या होता है, Z score क्या होता है? 68 years वाले बुड्ढी को 68 years वाले बुड्ढी को कंपेयर करे तो मिलने वाला कंपैरिजन को क्या बोलते हैं? T score. 68 year वाले बुड्ढी को 25 year वाले जवानी को कंपेयर करे तो that score. That we don't consider, but T we consider. Now, hyperthyroidism can go to gynecologist because of the abnormal uterine bleeding. That's the reason menorrhagia also you need to do endocrine profile. Then decreased libido, infertility. Infertility is not because of decreased libido necessarily. Libido is different from infertility, I think you are very sure. Even you get desired one night also, you can become pregnant. So libido has, or potence has no relation. A guy who is completely impotent can drop one sperm accidentally, like Anjaneya going on Indian Ocean, and produce in a fish who drinks the seminal drop and become pregnant. Abba, what a beautiful stories our people write. Most creative writers are our mythological storytellers. So, decreased libido, infertility, hyperactivity, restlessness, insomnia, fine tremors, all these are the typical features. And there is an increased LDL. Hypercholesterolemia is a feature of both hypo and hyperthyroidism. So, what do you see here, doctor? Lid lag. Lid lag in a person who is having, you are able to see the scleras white also generally, which is not seen. So how do you treat, doctor? Hyperthyroidism, we have two choices. One is called thionamides, other are called you have propylthiouracil and methimazole. They both block the thyroid peroxidase fundamentally. And propylthiouracil also blocks 5-deiodinase. What is 5-deiodinase? T4 become T3 by the action of 5-deiodinase, peripheral conversion. And between PTU and methimazole, methimazole is never given in the first trimester of pregnancy because it can lead to fetal scalp defects. One temporal bone के बजाय मिस को के पैदा होगा बेटा अगर मेथिमाजोल दिए तो मदर को, प्रेग्नेंट मदर को. So fetal scalp defects is the main challenge by giving methimazole. The season PTU is the one which is preferred because methimazole is teratogenic, is what you need to basically remember. But in second and third trimesters, methimazole is given because if you give PTU has a risk of leading to hepatotoxicity. So when you tomorrow become gynecologist obstetrician, the more general medicine you know, the better you are. Or at least keep a couple of your general medicine classmates nearby. In fact, a lot of my cases I see, I get a huge referral from my students who are gynecologists, right? So you'll send cases, right? That's a deal. Okay, 30% cut. Now, what are the side effects of PTU? PTU can lead to agranulocytosis. WBC count will fall down. Patient can go into leukopenia. That can lead to severe throat infections, etc., etc. That's the reason always before you start propylthiouracil, get a CBP and look for the WBC count. And after you started propylthiouracil, regularly monitor the CBP to look for any granulocytopenia. Right? So there are few drugs which are notorious to lead to granulocytopenia. What are they? Clozapine. Have you heard that drug in Mehboob Nagar? Clozapine is an atypical antipsychotic. Right? That is also known to lead to severe granulocytopenia. Second is what? Propylthiouracil. Propylthiouracil also can lead to granulocytopenia. That's why you have to be very careful to get the CBP checked. Huh? Carbamazepine lead to aplastic anemia direct. అది అంతసేపు కూడా వెయిట్ చేయదు. All 3 cell lines will fall down sometimes with carbamazepine. Carbamazepine can cause Steven Johnson syndrome also. Simple diclofenac can cause Steven Johnson. You have to be very careful while giving drugs, doctor. So aplastic anemia. Then hepatotoxicity can occur with PTU. PTU can cause ANCA positive vasculitis, is what you need to remember. That is all the story about hyperthyroidism, propylthiouracil, neomercazole tablets, propylthiouracil. So next comes Hashimoto's thyroiditis. Just because it is Hashimoto, don't think that it is only seen in Japan. Or don't write a short answer. It is the thyroid problem in Tokyo. Etiology. Because Japanese eat the fish. Fish can cause Hashimoto thyroiditis. Don't write the answer. I know. दो तीन पॉइंट मैं बोलता हूं, वो याद रखना, उसके ऊपर स्टोरी बनाना. Hashimoto's thyroiditis is the chronic autoimmune thyroiditis. In fact, a lot of patients who are hypothyroid, whose TSH is 7, 8 will come to you and say, my daddy didn't have, my mummy didn't have, nobody have. Why did I get thyroid, doctor? Because you're in India where Hashimoto's thyroiditis is common. It is an autoimmune thyroiditis. Your own immunoglobulins planned assault on your own thyroid gland. The most common cause of the hypothyroidism in the iodine sufficient areas. Even though you are eating Tata salt, why did I get hypothyroidism, doctor? Patient will ask you. Ratan Tata ko pucho. So patients read Google. They will only know iodine खाए तो क्या नहीं मिलेगा? Hypothyroidism नहीं आएगा. कोचिंग लिए तो सीट मिल जाएगा. वो जितना मिथ है, ये भी उतना मिथ है. What do you say, Ujjwala? Taking coaching does not guarantee seat. Going to infertility center does not bring pregnancy always. Right? But coaching centers, coaching gurus are like infertility specialists. If the adjacent coaching center fails, you have a chance to succeed. Probability theory. Understand? इसके लिए हम अपने आप पढ़ना है. पढ़ने के लिए थोड़ा मोटिवेशन चाहिए. वो मोटी को वेट करने के लिए हम बैठ गए हैं 8 घंटे बकते हुए. Coaching guru comes from Delhi, morning 8 o'clock to night 8 o'clock to 10 o'clock he is teaching. That shows how much he is afraid of his wife. He is not ready to go home. He is not ready to go. दिल्ली में उनका शैतान बीबी वेट कर रहे. कितने पैसे लाए हो? नहीं. I don't want to go. You please sit. I'll continue coaching up to 10 o'clock. If I go home, she will kill me. Understand? So, morning 8 to night 10, such much hai? Is it true? Padmanabhanagar coaching centers run 12-14 hours. Amma. Concentration camp. So now, Hashimoto thyroiditis is the most common cause of the hypothyroidism in the people who are regularly eating Tata salt. Right? Even you go to Tata, Hashimoto will be behind. Then patient will have an enlarged thyroid. This also is a very common diagnosis. Hypothyroidism patient may thoda enlarged thyroid hai, so they will be walking around railway stations, metro, everywhere you will find. But nobody diagnosed it till now. Right? So that's very important. And serologically, anti-thyroid peroxidase, which is called antimicrosomal, anti-thyroglobulin antibodies typically will be positive. So any newly detected person with high thyroid TSH levels with hypothyroidism, in the workup, what will you write? antimicrosomal, antithyroglobulin, actually not needed. Anything finally you will treat by giving thyroxine, thyronorm. Huh? But still laboratory fellow will be happy because your brother-in-law will be running lab now. Sister-in-law is a gynecologist. Brother-in-law will be lab. MBBS, enough. You can send patients here and there and make money. So anti-thyroglobulin antibodies, anti-thyroid peroxidase antibodies. Histologically, what do you see if you do by chance biopsy? Because pathologist, another brother-in-law unemployed. उनको भी थोड़ा मिलेगा ना, जाओ वो जाके थोड़ा फाइन नीडल डाल के निकालेगा वो एनलार्ज्ड थायराइड से, वो बोलेगा बावगारू Hurtl cells lymphoid aggregates with germinal centers are there. That is classical case of Hashimoto thyroiditis. Hurtl cells, lymphocytic infiltrate into the thyroid gland, right? With germinal centers. That's the reason Hashimoto thyroiditis can be a risk for developing lymphoma, is what you need to basically remember. Okay, Hurtl cells. Next comes De Quervain's thyroiditis. एक जापान हो गया, next फ्रेंच को जाएंगे. De Quervain's thyroiditis. So Hurtl cell कहाँ रहता है बेटे? Hashimoto. And non-endemic areas में most common cause Hashimoto. Hashimoto, right? And what are the two types of antibodies you see? Antithyroid peroxidase and antithyroid globulins. Another thing is Hashimoto mein initially those thyroid follicles are there, no? They will be broken and released because of the autoimmune destruction. Release all the available thyroxine. So initially there can be a hyperthyroid state. After that it gets depleted and leads to hypothyroid state. The initial hyperthyroid state is called hashitoxicosis, right? So that is very, very important. A lot of times this happens. Patient comes to you with undetectable TSH. One of my patient, Rafiq Sultana from Malakpet. ये क्या है डॉक्टर? मेरी बेटी बहुत पतला था, पूरा हिल रही, और मैंने डॉक्टर साहब के पास लेके गया तो उसने बोला देखो टीएसएच बहुत लो है, रिपोर्ट्स भी रहता उनके पास, इसलिए हाइपरथायराइडिज्म है बोल के नियोमार्केजोल दे दिया एंटीथायराइड. कॉलेज जा रहे, कुछ दिनों के बाद 6 हफ्ते हो गया और मेरे लाडली बेटी हेयर गिर रहा है, मोटा बन गया, वो जिंदगी में कभी भी इतना मोटे नहीं है. अभी टेस्ट करे तो TSH है. तो she don't know whether to blame laboratory or the earlier doctor or the neomarkazole or what? Her daughter. And her husband is saying, बाजू में husband खड़े होते, नहीं तू पिज्जा खिला रहे हो उसको, मैंने बोला ना पिज्जा नहीं खिलाओ बोल के, इसलिए वो मोटा बन रहे. Then what will you tell? It is called hashitoxicosis, which she got in earlier. And now what she is having is Hashimoto's thyroiditis. That is the reason. Now she is in the hypothyroid phase. Earlier she was in hyperthyroid phase. Don't blame pizza and Swiggy, right? And you will clarify them. So this is a very common thing that you come across clinical practice. Now let us talk De Quervain. De Quervain को बोलते हैं subacute granulomatous thyroiditis. Granulomas मालूम है ना? Caseous granulomas are found in TB. Non-caseous granulomas are found in sarcoidosis. Beautiful. You said sarcoidosis? Good. Usually, Subacute granulomatous thyroiditis is self-limited disease. It may be transient hyperthyroidism, then euthyroidism, then hypothyroidism, finally become euthyroid, ultimately euthyroid. The only thing is, you'll be treating hyperthyroidism when they are hyperthyroid, you'll be treating hypothyroidism when you are hypothyroid, and ultimately they themselves become euthyroid, but you will become Bhagwan in their life. Right? Yesterday only, one of my patient, she's a nurse, Padma. So she's 49-year-old. She had fever with severe joint pains. This time, a lot of viral infections led to joint pains in people. So मैंने उसको hydroxychloroquine 200 milligram morning and evening दिया और naproxen anti-inflammatory दिया और fluviroziltamivir भी दिया. So she got completely relief from the joint pains. Sir, మీరు నా జీవితంలో కలియుగ దైవము అమ్మో కలియుగ దైవము, she said. I said, అంత పెద్ద మాట నాకమ్మా, I have still want to live, don't want to retire as a physician. So one patient will say Kaliyuga Daivam, another will say you are Bakasura. You are eating on patients' money, you are an unethical doctor, but what will you as a doctor? You will not be touched by compliment or criticism. Why river Ganga is called holy river? One of my professors used to tell, people pass shit into it. People wash buffaloes in it. And few people do Deeparadhana and pray it. Will Ganga will stop for anything? No. Ganga continue to flow irrespective of buffaloes washed or people pray. So you will also be like that. Sthitidi, sithadi, munivruhyati. You should be having that equanimity to accept criticism, slap, glass breaking by the patient, or he will call you Kali Yuga Daivam. Understand? So these things are very important, more than all this subject we are discussing, doctor, let me tell you. So, what are the classical features of subacute granulomatous thyroiditis? Granuloma is inflammation. That's the reason high ESR, jaw pain, very tender thyroid. Unlike Hashimoto, which is non-tender thyroid enlargement, this is tender thyroid. D. quervain means pain. D. quervain is associated with pain. And histology is granulomatous inflammation. So this is the granulomatous subacute thyroiditis, where multinucleated giant cells against a background of colloid and blood is what you are able to see. Then comes Riddle's thyroiditis. So Riddle's thyroiditis का स्टोरी क्या है? इसको कहते हैं इन्वेसिव फाइब्रस थायराइडाइटिस. थायराइड में इन्फ्लेमेशन आके पूरा फाइब्रस हो जाता, एक वुड के जैसे बन जाता थायराइड ने. It can be related to IgG disease, means what? Retroperitoneal fibrosis, autoimmune pancreatitis, non-infectious aortitis. With Riddle's thyroiditis comes like a Dashara package. A सबको common underlying thing is IgG related diseases, they are called as. Understand? It is a systemic fibrosing disorder. हर एक जगह उनका fibrosis होते जाता. Then hypothyroidism in Riddle's thyroiditis occur in about 1/3 of patients. And that fibrosis of the thyroid will extend into the trachea, into the esophagus. Sometimes it will be confused for anaplastic thyroid carcinoma. Thyroid में कितने types हैं? Papillary, follicular, medullary, and anaplastic. If 20 people come, I'll definitely take surgery class in 3 days. 10, huh? Chalo, 10, paying 3,000 rupees. फीस 3 दिन में खत्म करेंगे. Huh? Jara ikkata karo. But don't say I will be single person paying you 30,000 and come and sit and teach it. Right? I have one USMLE student. Her father is a top neurosurgeon. ఏదైనా డాక్టర్ గారు మా అమ్మాయికి మీరే దిక్కు దయ 3 lakhs he is paying to me for taking 2 1-hour classes per week for USMLE step 1 coaching. Yeah, I'm a good money laundering guy. I'm not all noble as what you think, what you don't think otherwise also. So now, Riddle's thyroiditis, it will slowly enlarge. It is hard, rock-like. It is fixed, non-tender thyroid. Once more, Hashimoto non-tender, D. quervain tender, Riddle non-tender, and thyroid is replaced by fibrosis. So this is how mutton shop ka mutton piece ke jaise Riddle thyroiditis, which is fibrous, or it is taken out from the oven, whichever the way. So this is how you can see histologically there is a development of fibrosis. Fibrosis in case of Riddle's thyroiditis. Okay, doc? Okay, sorry. I'm I'm writing on the Apple here. Yeah. Okay. So that is Riddle's thyroiditis. Sundays are the time of playing cards and whiskey. So all my mood is now on that side of playing rummy with a Cuban cigar with a single malt whiskey waiting. So that's the reason this is going somewhere. So this is how, doctor, what you see? Riddle's thyroiditis with fibrosis. Clear? Now comes Graves' disease. A lot of patients, I have one patient by name Suresh Sundaram. He was a vice president of Reliance. His wife actually diagnosed Graves because she read in Google. She came, my husband became very irritable. अगर इसको देखे तो सब लोग हिल जाते, मगर ये हिल रहा है आजकल. Tremor is there. And he used to have a very pretty look at me, Mr. Suresh Sundaram, the very supportive Tamilian husband to Meenakshi Sundaram, his wife. Then, doctor, I went to Google and I found, doctor, that there must be some problem, doctor. Then I said, well, get a TSH done. TSH is undetectable. I said, Meenakshi, you are a very brilliant wife. Meenakshi from Madurai is brilliant wife. So, treated her husband. He became all right. All her, his gussa nikal gaya baby ke upar. And his office also said there's a personality change in the person who is otherwise a very friendly boss. Reliance means a lot of stress. Sweet stress. Reliance Industries bolito. But he used to be a cool boss, became an angry boss, once more became cool boss after treatment of Graves' disease. That's the reason thyroid disorders a lot of times are discovered by brilliant wives. Just you need to be a little more intelligent than her to diagnose after doing MBBS. But MBBS will make you dumber than a housewife. So that's the reason thyroid is missed. Most common cause of hyperthyroidism is Graves. Graves may why hyperthyroidism. Normally, who stimulates the thyroid to produce the T3, T4, TSH? इधर क्या हो जाता ना, there will be thyroid stimulating immunoglobulin G. So this immunoglobulin has a special property. It is the one which acts like TSH and stimulates the thyroid, and thyroid, unknowing that it is not TSH but the IgG, without knowing that, it will start producing thyroid. So here what is happening? Antibody is going and attacking a fixed antigen. That's the reason it is an example of type 2 hypersensitivity. So it's called as LATS, long-acting thyroid stimulating antibody, which will go and stimulate the TSH receptors. So there will be hyperthyroidism, a diffuse goiter, pretibial mixed edema, and Graves' orbitopathy with the exophthalmos and all. Now, what is the speciality of Graves'? Graves' is most common cause of hyperthyroidism, but there are many other causes of hyperthyroidism. You have seen all thyroiditis initially will cause hyperthyroidism. In a case of hyperthyroidism, we recognize it as a Graves' only if ophthalmopathy is there. A hyperthyroidism without ophthalmopathy, with a staring looks of somebody, you can't diagnose it as Graves'. Just like without retinopathy, it is not diabetic nephropathy. Okay? That's very important. So there will be a lot of hydrophilic glycosaminoglycans which are produced. There is a fibroblast proliferation, exophthalmos, and typically periods of stress like pregnancy can precipitate Graves'. And HLA-DR3, HLA-B8, these are the numbers that you need to remember with Graves'. So if you do testing of the thyroid histologically, tall, crowded follicular epithelial cells with a scalloped colloid. Tall, crowded follicular epithelial cells, because constantly that LATS, long-acting thyroid stimulating antibodies stimulating them, so they are producing colloid, is classical of Graves' disease. So once Graves' is there with hyperthyroidism, significantly, it can lead to osteitis, inflammation of the bone, typically seen in the phalanges. And there can be clubbing, that's called thyroid acropathy, is the feature of the Graves'. Now, if you do radionuclide scintigraphy, radionuclide uptake will be diffusely increased in Graves' disease. Radionuclide scintigraphy is very important. Very important. You're fine? Scintigraphy is very important. This is what, in radionuclide scintigraphy, there is an area of no uptake. So this is a focal area of increased uptake is there. It is a hyperfunctioning nodule. Here, there is a diffusely increased uptake is there. Here, there is a reduced uptake is there. Reduced uptake is a feature of thyroiditis. Diffusely increased uptake is a feature of Graves'. Focally increased uptake is a feature of toxic goiter, toxic nodule. And in Graves' disease, what do you find? Follicular cells which are tall and crowded with the scalloped colloid is the description. Next comes toxic multinodular goiter. Name only will tell, na, multiple nodules are there, there is a goiter, means enlargement is there. It is toxic. What else? 5 marks, khatam na. It increases in high T3, T4, and focal patches of hyperfunctioning follicular cells will be there, and they are called hot nodules. And what is the rule about hot nodules, cold nodules? Hot nodules are only rarely malignant, cold nodules possibly malignant. So this is how there will be increased uptake of the radionuclide when you do scanning. thyroid storm. It's an emergency and a serious condition. In a patient who is already hyperthyroidism, whenever he has infection, trauma, or you posted him for surgery, he will go into agitation, delirium, fever because of excess sympathetic activity, diarrhea, coma, tachyarrhythmias, increased LFT. That's called thyroid storm. So how will you treat? 4 P's. P for propranolol, beta blocker. Why? Propranolol beta blocker will decrease the peripheral conversion of T4 into T3. P for propyl thiouracil. P is prednisolone, which is a glucocorticoid. And potassium iodide. Why potassium iodide? Wolff-Chaikov's effect. If you use excess iodine, it will suppress the thyroxine production. Wolff-Chaikov effect. So this is the Lugol solution of iodine, Lugol's iodine. 1950s में भी ये है. Some treatments are very old. Jod-Basedow phenomena क्या है? Opposite to Wolff-Chaikov. It is iodine-induced hyperthyroidism. Right? Suppose if you happen to give iodinated IV contrast, or if you happen to give Amidaron also contain iodine. So it will lead to hyperthyroidism, which is called Jod-Basedow, which is opposite to Wolff-Chaikov. Then comes goiter. All causes of goiter you should know when you go for exam. Smooth diffuse goiter, Graves' disease, Hashimoto, iodine deficiency, TSH secreting pituitary adenoma. Nodular goiter is seen in toxic multinodular goiter, thyroid adenoma, thyroid cancer, and thyroid cyst. Then comes hypoparathyroidism. Parathyroid is not working because autoimmune destruction or parathyroid glands are produced from brachial arches 3 and 4. What is paradox there? 4 produce superior, 3 produce inferior. Entrance के लिए hot areas, right? Dijorge syndrome is congenital aplasia of thymus with parathyroid, hypoparathyroidism, right? And whenever always remember, hyperparathyroidism is synonymous with hypercalcemia, hypoparathyroidism is synonymous with hypocalcemia. Clear? Now, hypocalcemia lead to tetany. Hypoparathyroidism may hypocalcemia which lead to tetany. And there will be hyperphosphatemia. ఇది తెలవాలి. ఇది తెలిసినోడు మహానుభావుడు చెప్తా. Yes. What are the effects of hormone? Right? First on kidney. Parathormone increase calcium reabsorption. So if there is no parathormone, there is no increased reabsorption, so hypocalcemia. If there is excess parathormone, increased calcium reabsorption, hypercalcemia. Simple, no brains. Whereas parathormone decrease phosphate reabsorption and lead to phosphaturia. Opposite to calcium is phosphate. That's the reason hyperparathyroidism lead to excess phosphaturia, leading to low phosphate in blood. Hypo lead to decreased loss of phosphate into urine, leading to phosphate retention, leading to hyperphosphatemia. Hypoparathyroidism is equal to hypocalcemia and hyperphosphatemia. Hypocalcemia ఎవరికి అర్థమైందా? హైపర్ఫాస్ఫేటేమియా ఎందుకు ఉంటుంది? Normally, parathormone will cause for phosphate lost into urine. If it is not there in hypo, phosphate is not lost into urine, it is back into blood. Hence, there is a hyperphosphatemia. Hyperparathyroidism is equal to hypohypemia. Hyperparathyroidism is equal to hypercalcemia and hypophosphatemia because all phosphate is gone into urine. Then how parathormone increase calcium reabsorption? Not directly. It will go and tell 1-alpha hydroxylase uto. 1-alpha hydroxylase converts 25 hydroxylase vitamin D into 125 hydroxyvitamin D, which is active form. 25 by hydroxyvitamin D is inactive. So it will increase vitamin D levels. Then on the bone, what will PTH will do? PTH will resorb the bone. Bone को पूरा खाइमा करके पाउडर बना के उससे पूरा कैल्शियम और फॉस्फेट को निकाल के ब्लड में डाल देगा. So it will cause the bone resorption. What is the effect of parathormone on? Does it have any effect on intestine? Not directly. It will increase the vitamin D. That vitamin D in turn will cause increased calcium absorption and phosphate absorption from the intestine into the blood. Okay? Now let us go back. So hyperparathyroidism में क्या होता? Tetany, hypocalcemia, hyperphosphatemia, Chow's-Tech sign, Trousseau's sign. What is Trousseau's sign? If you put the cup and then inflate, it will lead to severe carpal spasm. Trousseau's sign. Normally calcium is how much? Around 8 to 10. Some people have 7, 6, 5 also. I have one patient in Barkatpura. Night में बोल के आवाज करते, किसी के समझ में नहीं आ रहे वो काई को कर रहे. तो they call, doctor, can you please come and see my mother? चलो, क्या प्रॉब्लम है? मैंने बोला, कू बोल के साउंड कर रहे सर, वो पाइगन के जैसे. तो मैंने गया, कू कू कू, इनको हैंड देके तो अयो, immediately almost I called an ambulance, took to Kachiguda TX hospital and then get calcium tested 6. तो वो कबूतर है को हमने सुंदर बनाया by giving calcium gluconate, correcting her vitamin D levels which are severely low. Only 2 or 3 was this vitamin D level, and she was very good. So that is called as luck. Should be lucky to get good cases. Understand? And just one day before, I had a patient by name Padma in Jagdirgutta. Suddenly, I got a call at evening 7 o'clock that she is in emergency state. Can you please come, doctor? Young lady, she's just 43-year-old. I rushed her. When I auscultated, no breath sounds. Percuss kare to stony dullness. Right? Then she is having acute shortness of breath. Oxygen levels dekhe to 84. Young lady. Then I told, she, with my stethoscope and hand maximum, I can tell there must be some pleural effusion. Probably pericardial effusion also. That's the reason she may be having shortness of breath. So she need to be admitted. So her husband is somewhere else in Khammam, Ongol. So I arranged an ambulance got her shifted. Then when we evaluated, there was severe pleural effusion, right? Severe pleural effusion, and she also has a complete heart block. So in emergency, we have to put a pacemaker. So then her daughter is a medical student. So she came and said, next day she was drinking milk. Her daughter came and said, I think my mom can be discharged. I said, Amma, complete heart block with a temporary pacemaker, with a bilateral pleural effusion, right? And last 3 weeks she is having a smoldering fever also. How can we? We cannot. We'll take some time. It will be all right and we'll shift to room. Then suddenly in the midnight she got a cardiac arrest. She went into VF and cardiac arrest. The intensivist tried to resuscitate. Finally, 3 times done also, she could not revive and died. 43-year-old means it's a shocking thing even for us, right? We did everything but could not save the patient. So, her father called, you killed my wife. He said, I don't need to come all the way to your home, carry her to the hospital and take care of her to kill your wife. No, you are not there when my wife is dying. I said, boss, there's a system. I'm a senior consultant and there is an intensivist who takes care. No, because of you only she died. And he started writing in all forums that Dr. Murali Bharat was killed. Then I called and told, I'll file a lawsuit on you if you happen to not remove all your stupid comments. I did the best to come to your home and take care. He removed all that. Same time, this patient of Barkatpura said, you are a god. I said, I'm not a god. I'm not a demon. I try my best. If I'm lucky, patients will be alive. If I'm not unlucky, young person dying means for about 10 days, you don't feel like touching food also. You feel, why this happened? But still we need to treat patients. We should not be lost, neither by compliment nor comment. So that's the reason the happiest time for me always is with all of you. You don't get seat also, you won't blame me. Right? If you get seat, by your hard work, I'll take credit. I'll say because of you, me only. Huh? Success has many fathers, mothers, mother-in-laws, father-in-laws, so many things. So that's the reason. Okay? But still you take coaching. Why? Because if you fail, at least you can blame the teacher. वो गधे के पास गया इसलिए ही मुझे सीट नहीं आया. Right. Now, Dr. Trojio's sign, you got it right? So, one case of hypocalcemia, dramatic recovery by giving calcium gluconate. You see, you will never forget. Then comes pseudo-hypoparathyroidism. मतलब क्या है? Parathormone is produced, but receptors are not responsive to parathormone. Receptor level resistance, just like nephrogenic diabetes insipidus is pseudo-hypoparathyroidism. Why the receptors are not responding to parathormone? Because there is an inactivating mutation called GNAS1, GNAS1, which is related to PTH receptor. So you should know all hormones have a secondary messenger. Parathormone has a secondary messenger which is ADH. ADH is cyclic AMP. Cyclic AMP is produced by the action of the adenylate cyclase which converts AMP into cyclic AMP. So the inactivation of the adenylate cyclase will make PTH secondary messenger not generated. Hence, even though it is switching the plug, PTH actions are not, bulb is not getting glowing. So, very commonly, pseudo-hypoparathyroidism is seen in Albright's hereditary osteodystrophy. What is that? What is that syndrome of hypothyroidism, congenital hypothyroidism, which side? Only Asia. చెప్పినావంటే అసలు సూపర్ నీ బ్రెయిన్ 3 words are there. That's called algebras. అమ్మమ్మ మీ ఆయన పేరేంటి? 2 పేర్లు ఉన్నాయి, పద్మనాభం. సో ఎవరైనా చెప్తారా? One is K, other is S, other is D. Kocher's debris semilangi syndrome. Understand? गाली देने के लिए अच्छा काम आएगा. So Kocher, Semilangi, debris. I never know why 3 names they will keep, because maybe in the country he belongs, polyandry is prohibited. So one night she can say, "Oh, Kocher, you are so good." Another night she can say, "Semilangi, you are too good." Depending on her mood, she can use any of the 3 names. So, what are the physical features in Albright's hereditary osteodystrophy? 4th and 5th digits are shortened. There's a short stature, round face. हमारे classmates में बहुत लोगों के पास होता है. Don't touch that. Subcutaneous calcifications, developmental delay. Hence, he became our classmate. Right? So, don't look at all round-faced classmates suspiciously. What is the lab? In these people, typically, calcium is low, but phosphate should be high, no? PTH also should be high. There is a little error there. So, you can see round face, short, 4th and 5th, little finger and this, and 4th and 5th. And if they happen to make a dimple, now 4th, 5th is missing now. So there you will find dimples instead of knuckles. Knuckles are metatarsals, no, because the shortening. That's called Archibald sign of Albright's hereditary osteodystrophy due to pseudo-hypoparathyroidism is what you need to remember. Next is pseudo-hypoparathyroidism. This is autosomal dominant. In this, what do you get? Paternally transmitted mutation. That is, मम्मी के तरफ से नहीं आता, किसके तरफ से आता? अब्बा के तरफ से. Imprinted GNAS gene. GNAS gene. But what is the speciality? Imprinted GNAS gene. That's the reason it is same like pseudo-hypoparathyroidism. But in these people, parathyroid is normal. It will only have the phenotypic features of pseudo-hypoparathyroidism, but not parathyroid dysfunction. Okay? But still you call it as hypoparathyroidism because it resembles pseudo-hypoparathyroidism. So, మూడునే ఇప్పుడు మనకి. ఒకటి actual hypoparathyroidism, true hypoparathyroidism. Other, PTH receptor level resistance due to GNAS mutation, which is pseudo-hypoparathyroidism with some physical features. Only physical features with normal parathyroid is pseudo-hypoparathyroidism is what you need to remember. So now let us look at the calcium level values, hypocalcemia values. This is a very important table. If there is a vitamin D deficiency or hypoparathyroidism or if there is any chronic kidney disease with a secondary hyperparathyroidism also, you will have low calcium. I'll come to this. And pseudo hypoparathyroidism also you have low calcium. And hyperphosphatemic individuals, phosphate marries calcium and lead to hypocalcemia. ఇవన్నీ హైపోకాల్సిమిక్ స్టేట్స్. చెప్పండి మళ్ళా. విటమిన్ డి డెఫిషియన్సీ, hypoparathyroidism, secondary hyperparathyroidism, pseudo hypoparathyroidism, hyperphosphatemia. In all this, there is a hypocalcemia. First, let us talk about vitamin D deficiency. Vitamin D causes calcium reabsorption from the kidney and also gut. It is not there means low calcium. It will also cause phosphate reabsorption in the kidney. It is not there means phosphate will be low. Then whenever vitamin D deficiency is there, when calcium phosphate is low, hypocalcemia stimulates the parathyroid to release the parathormone. That's the reason PTH levels will be high. And that PTH will go and cause the bone to release the calcium phosphate, and that lead to alkaline phosphatase levels increased and vitamin D levels is low. ఇందులో అన్నీ ఓకేనా? నెక్స్ట్ hypoparathyroidism. Hypoparathyroidism, calcium is low but phosphate is high. PTH is low but alkaline phosphatase is normal, because alkaline phosphatase will increase only when bone is dissolving. That happens when parathormone is high, not low. And vitamin D levels are low. Why? Because parathormone is needed to convert 25 vitamin D into 125 vitamin D. If it is not there, means vitamin D is low. Then what is secondary hyperparathyroidism? Those patients who are having chronic renal failure, CKD, 125 vitamin D cannot be produced because 1-alpha hydroxylase is produced by kidney. Because of that, there is a low vitamin D that will lead to hypocalcemia that stimulates parathormone, and hence that is the situation. So that's the reason fundamentally they have a low calcium. Why? Because vitamin D is not there. Their parathormone levels are high, but their phosphate levels, even though it is a hyperparathyroidism, then hyperparathyroidism means what will you expect? Phosphaturia. So low phosphate you expect, but they will have high phosphate. Why? Because this secondary hyperparathyroidism occurring in a kidney failure patient. If your kidney fails, it is a phosphate retaining situation. There is no way to get rid of your phosphate from the body if the kidney is not working. That is the reason in secondary hyperparathyroidism, phosphate levels will be high. Whereas primary hyperparathyroidism, phosphate levels will be low. That is the differentiator. Gurtuntada? Ujjwala? Difference enti? Primary ki, secondary ki? Phosphate levels. Primary hyperparathyroidism low because there is a phosphaturia. Secondary hyperparathyroidism is because of kidney disease, which will retain phosphate. Hence, there will be hyperphosphatemia in secondary hyperparathyroidism. Okay, beta? And alkaline phosphatase will be high because any parathormone will go to the bone and dissolve the bone. Hence, alkaline phosphatase increase. Next comes pseudo hypoparathyroidism. There is a low calcium, but fundamentally parathormone is not working. That's the reason phosphate levels will be high, because that lead to phosphate retention. Ante kada? Parathormone lead to phosphaturia. No parathormone, whether receptor level or any level, will lead to high phosphate. Alkaline phosphatase is high. PTH levels are high. And also pseudo-hypoparathyroidism is due to PTH receptor level resistance. So in these people, vitamin D levels are increased because parathormone goes and stimulates a lot of 1-alpha hydroxylase. Uske liye it doesn't require receptors. That's the reason. Then comes hyperphosphatemia. You'll remember, right? Next, hyperparathyroidism. Unnada opika? Time ente? 5. 5 बज गए. Diabetes खत्म చేసుకోదాం. Then is pseudo-hypothyroidism. Pseudo-hypothyroidism. Professor Mubin, what is pseudo-hypothyroidism? Receptor level resistance. Pseudo-hypoparathyroidism is receptor level resistance. So when PTH is produced normally but not able to act on receptor. Why receptor? Genase mutation. It's called Albright's hereditary osteodystrophy. So when the PTH is not able to act on the receptor, it leads to hypocalcemia. It leads to phosphate retention and hyperphosphatemia. Because normally parathormone will cause phosphate lost into urine. If it is not working, phosphate is retained. And that leads to dissolution of the bone, leading to high alkaline phosphatase. And there are some physical features there in the pseudo, like short fingers, 4th and 5th, dimple sign of Archibald, etc., etc. Okay, clear? Now, hyperparathyroidism, 2 kinds, primary, secondary. Secondary in kidney disease, which we already finished. Primary means when there is a parathyroid adenoma, it produces excessively. And typically it lead to parathormone, lead to phosphaturia, leading to hypophosphatemia. Clear? And cyclic AMP levels in urine will drastically increase. A lot of times they are asymptomatic. But because of this hypercalcemia, they can present with constipation. You know, Shalcol tablet liye to logon ko, kuch logon ko constipation aata. Calcium tablet liye to constipation, hypercalcemia. Then it leads to kidney stones. And calcium can go and injure the pancreas, leading to pancreatitis. So either stones or pancreatitis lead to abdominal groans. Then hypercalcemia can cause psychiatric overtones with neuropsychiatric disturbances. How is only calcium knows why it is mad, right? Then bone pain. By parathormone will go and dissolve the bone, leading to bone become porous, leading to bone pain. Okay. One patient, Sharwani, ऐसा touch करे तो she used to cry. 34-year-old, she used to work for Infosys. Then when I met her, I did not guess it will lead somewhere. Just testing करे तो 13 was her calcium level, 13. General का vitamin D deficiency undi hypocalcemia है तो you will get to bone pain. Why will hypercalcemia lead to bone pain? That is where Sherlock Holmes will start thinking. Got her PTH done, PTH is high, and got her ultrasound of the neck and parathyroid adenoma found. It has been extirpated. And all her bone pain is because of the osteitis fibrosa cystica. I have her CT image also, very classical. So that's the reason patients don't present exactly like picture. Textbook. They'll present like one single line in the textbook. From there, entire paragraph page ko padna padta. That is only possible if you look for it. Okay, clear? Osteitis fibrosa cystica is when the bone got resorbed with the brown fibrous tissue, brown tumor, because parathyroid will go and tell osteoclast to resorb the bone. Osteoclast will act over. Authorized constructions also they will destroy because it is in FTL zone. Huh? So that lead to brown tumor. Stones, thrones, bones grown, psychic overtones is hyperparathyroidism and osteitis fibrosa cystica. So this is a 48-year-old woman with osteitis fibrosa cystica. Loss of the lamina dura of the upper teeth is a feature of osteitis fibrosa cystica. You can see a cystic lesion, osteitis fibrosa cystica, etc., etc., because of the resorption of the bone. So there is an entity called primary, secondary, tertiary hyperparathyroidism. Ante enti? Suppose you have chronic kidney disease for a long time, low vitamin D, for a long time hypocalcemia, for a long time parathyroid gland is demanded to release PTH, then what will happen to it? It become autonomous. Even though you brought a new kidney and placed, you corrected calcium, without calcium also it will start continuing to produce PTH. That is called tertiary hyperparathyroidism, is what you need to remember. Then there is an entity called familial hypocalciuric hypercalcemia. What is the meaning of it? FHH. Generally, parathyroid glands to produce parathormone in response to hypocalcemia, or kidneys to reabsorb calcium in response to hypocalcemia. There is some threshold. Suppose if the threshold increased, that means even hypocalcemia is there, 7 is there also, kidney still not sensing it. 6 ko gaya, calcium levels in serum, still it is not sensing, but it is only losing calcium into urine. That lead to calciuria with hypocalcemia because of inability of G-coupled calcium sensing receptors in parathyroids and kidneys being defective in them because of the genetics. Understand? These people will have hypocalciuria with mild hyper. What did I say just now? Opposite I said. They fail to sense time to lose calcium into urine. Sorry, not hypocalcemia sensed, hypercalcemia. Hypercalcemia ఉందనుకోండి, 10 వచ్చేసింది అనుకోండి, or 11 calcium levels, immediately kidney should sense high calcium is there, so it should secrete calcium. But it is not sensing, and threshold became higher, even 13, 14 also it is not sensing. So that is the reason what will happen, calcium is no more lost into urine, and that lead to familial hypocalciuric hypercalcemia. Clear? So that is a entity where there is a increased PTH production in spite of high calcium. Normally, what should calcium should do? High, if the calcium levels are high, hypocalcemia stimulates parathyroid. Hypercalcemia inhibit. But calcium sensing receptors are not working in parathyroid. That's the reason parathyroid continued to be produced in spite of hypercalcemia. Similarly, in the kidney, whenever the calcium is high, what should happen to the calcium uh, reabsorption should come down and it should be lost into urine. But kidney could not do that. Why? Because all this PTH is very high. The problem fundamentally is in PTH, in the parathyroid. So this high PTH is coming and making the kidney to continue to reabsorb the calcium in spite of hypercalcemia. I'll come back to you in a more easier way. Normally, there is a samjhota. What is the samjhota? Low calcium should stimulate parathyroid to produce PTH. High calcium should decrease the PTH. But in these people, calcium sensing receptor is abnormal. Because of that, parathyroid is not sensing hypercalcemia. So normally hypercalcemia should suppress PTH. But here it is not suppressing and continuing to produce PTH. And this PTH is causing continuous calcium reabsorption. That's the reason there is a hypocalciuria leading to hypercalcemia. But that hypercalcemia is unable to suppress the PTH and PTH continues to be high in spite of hypercalcemia. Okay, that's what you need to remember. Last topic of the entire medicine season. So I hope after you get distinction score in final year, no? Surely you will get, because you will blast examiner left and right. If he knows, if he doesn't know Ram K, you tell Ram K. If he knows Ram K, you tell Lakshman K. Something or other you tell, right? And he should feel like giving gold medal. In cardiology, you know what is early diastolic murmur, what is Austin Flint murmur, what is Graham Stills murmur, what is Ritton's murmur. With your knowledge, examiner will get a brain stroke. Now comes diabetes. Emma? 5 minutes break.
5 minutes break for
Prayer, right? Okay, sure. Definitely. సో మీరు ఎక్కడ ఉంటారు డాక్టర్? ఎక్కడ? గాంధీ హాస్టల్. యూ కెన్ కమ్ నో ఈవినింగ్. Oh, you are doing internship. Huh? Sunday mock test, Randy. Mock test and discussion we have, and Wednesday to Saturday we have a PYQ session whenever you get time. Huh? Offline. Nothing is more interesting than offline. Online must dorte. Offline boring ఉంటుంది. ఆన్లైన్ ఉంటే అదే ఆన్లైన్ బోరింగ్ ఉంటుంది, ఆఫ్లైన్ ఉంటే దట్స్ ఎ డిఫరెంట్ థ్రిల్. వాట్ ఈస్ సే? సో ఇప్పుడు మీరు ఎంబీబీఎస్ ఫస్ట్ ఇయర్ నుంచి గాంధీగా? అచ్చా అచ్చా. ఇప్పుడు గాంధీ టాప్ కాలేజా ఈఎస్ఐయా? టాప్ ర్యాంకర్స్ ఏది తీసుకుంటారు? ఈఎస్ఐయా? ఐ హర్డ్ దట్ గాంధీయేనా? గాంధీ క్రౌడ్ ఇస్ ద కిక్. ఎంత 250 బ్యాచ్? మేమున్నప్పుడే ఇట్ వాజ్ 130-25 years ago. ఇక్కడ గాంధీ మజా ఉండేది. ఇక్కడ పక్కన బషీర్బాగ్లో గాంధీ ఉండేది కదా. దట్ వాజ్ ఏ హిస్టారికల్ ల్యాండ్ మార్క్. అనవసరంగా దే డిస్ట్రాయిడ్ ఇట్. హ్యూజ్ క్యాంపస్, వీ యూస్ టు ప్లే క్రికెట్ ఇన్ ద క్యాంప్. ఇప్పుడు ఉందా ఇక్కడ గాంధీలో క్యాంపస్? అదే క్రికెట్ అన్ని ఆడడానికి. అచ్చా. And people after internship they still study in Gandhi Library. Permitted? No. అంటే రీడింగ్ రూమ్ ఉందా గాంధీలో? బట్ ఓన్లీ వెన్ యు ఆర్ ఎ స్టూడెంట్. Yeah, it will also be online, live broadcasted. You can attend, but when you get time, if you can come, that will be altogether good. So, how many in your batch are preparing for USMLE? 50 మంది ఉంటారా? Not sure. మీరు మెడిసిటీ కదా? ఏమైంది మీ ఫ్రెండ్ ఏమైంది? తన పేరేంటి? కీర్తి. Okay, sir. Now, diabetes, polydipsia, polyuria, polyphagia, weight loss is the presentation. Type 1 and type 2, type 1 में absolute insulin deficiency, type 2 में insulin resistance. Insulin is on one side, and what is opposite party? Growth hormone, glucagon, epinephrine, all of them come on the other side. That's the reason COVID may we have given so much steroid to the people that we ended up a lot of people into diabetes. Now, what are the chronic complications of diabetes? They're divided into microvascular and macrovascular. Small vessel disease. Why do you get small vessel? Because diabetes lead to thickening of the basement membrane. Retinopathy is a microvascular. There can be hemorrhage, exudates, microaneurysm, and neovascularization into the retina. They're all the retinopathy. Glaucoma is more common in the people who have diabetes due to microvascular. Nephropathy, microvascular, leading to nodular glomerulosclerosis with a progressive proteinuria. That's the reason in all the diabetic individuals, we start telmisartan 20 milligrams, even if there is no hypertension, in order to avoid diabetic nephropathy. Arteriosclerosis leading to hypertension, leading to chronic kidney disease is the feature of microvascular complication of diabetes. Then what is meant by large vessel disease? Coronary artery disease, peripheral vascular disease. A person with diabetes with peripheral vascular disease, a little walking will lead to intermittent claudication. Gangrene, cerebrovascular disease, that is stroke. MI, the most common cause of death, is a macrovascular complication of diabetes. And diabetes can lead to macrovascular and osmotic damage. When diabetes is not controlled, there is a hyperglycemia and all that glucose is converted into sorbitol by the action of aldose reductase. And sorbitol gets converted into normally fructose. But if it is not or excessively produced, that will go to the lens, drag water into it, and lead to cataract. So, osmotic damage due to sorbitol accumulation. Similarly, neuropathy is also a large vessel disease. So, what kind of neuropathy it is, doctor? Gloves and stockings distribution. Typically, if you look at the diabetic neuropathy, there are 5 kinds. Large fiber neuropathy, vibration, position, touch is all carried by large fibers. Small fiber neuropathy, pain, temperature is carried by small fiber. That's the reason diabetic individuals say burning sensation in my hands and fingers, paresthesias, is all because of small fiber neuropathy. Then proximal motor neuropathy, if you look at the legs, they'll be almost like sticks. Because of that, proximal motor neuropathy. Then acute mononeuropathies, acutely single nerves like facial nerve, oculomotor nerve, anything can undergo paralysis, which is called acute mononeuropathies, then entrapment neuropathies. These are all the features of diabetic neuropathy. Clear? So, doctor, over a period of time, the patients of diabetic neuropathy will go into autonomic neuropathy. That is the time they develop gastroparesis. Into doctor garu pottanta obbipoyinattu anpistundi. Diabetic neuropathy, autonomic neuropathy. Gastroesophageal reflux disease. Continuous loose motions in a diabetic can be because of the diabetic autonomic neuropathy. Constipation can be because of autonomic neuropathy in diabetes. And cataracts. So these are all the osmotic effects of diabetes. So three types: small vessel, large vessel, and osmotic effect. Under osmotic effect, you have neuropathy, cataracts, autonomic degeneration, etc., etc. Okay? Now, this is called stocking and glove distribution, where the vibration touch sensation is gone. And because of that, what will happen? If you are not able to perceive the touch of the ground, what will happen? You will slip and fall. That lead to fracture. Fracture lead to immobilization, immobilization lead to decubitus ulcer leads to sepsis, sepsis lead to death. That's how a great man died. Because of pulihora fed by her husband, wife. Right? So never, when some middle-aged guy is diagnosed with diabetes, call his wife. Annapurna. Bhojjeshu mata, sayaneshu ramba, karyeshu mantri. And or one more. So food department, if stop feeding rice, wheat, and start feeding millets, jowar, jonna, ragi, korralu, stop బియ్యం విషం, గోధుమ విషం, రాగులు, జొన్నలు, మినుమలు, సజ్జలు, కొర్రలు ఇవి తినాలమ్మా అని చెప్పాలి. రైట్? Stock and glove distribution, large fiber disease, typical of diabetes. And diabetes, that touch sensation gone means that lead to ulcers. There are few MS general surgery guys who are called foot surgeons, podiatrists. They will only take care of foot and they become billionaires. 10,000 feet are my goal, says one of my friend Karnakar. He's a surgeon in Bangalore. 10,000 feet is my goal. Next to 10,000 feet, I'm going to build, buy the villa. First 10,000 feet, Mercedes. So, podiatric surgeons. So now, how do you diagnose diabetes? HbA1c will give you a cumulative retrospective analysis. Below 6 is no diabetes, 6 to 7 controlled diabetes, above 7 uncontrolled, and 8 poorly controlled. Fasting plasma glucose, what is the cutoff? 126. Fasting how much time? More than 8 hours. Then 2-hour glucose tolerance test. You'll give 75 grams glucose and look for, after 2 hours, plasma glucose more than 200. And any random plasma glucose more than 200, they're all diagnostic findings. So I leave to you what is differences between type 1 and type 2 in the literature. Just review that. There's no rocket science to learn about it. And diabetes may, if you over aggressively treat, the patient will end in hypoglycemia, which we need to be careful. Especially patients with chronic kidney disease will have hypoglycemia. Why? Kidney, what will it do? clears insulin. The moment chronic kidney disease develops, insulin clearance decreases. Little insulin stays longer. Their same dosage of drugs you are giving, Ankondi. Then they will end up in hypoglycemia. Early morning, nurse will call you to the duty room. Bed number 4, not responding. At least you respond, doctor. And when you check it, what happened night, mixed order, same 30 units patient is taking. That's the reason hypoglycemia, neurohypoglycemic episodes leading to sudden death is very common. Now comes diabetes treatment. This is important. Type 1 diabetes, there is no other treatment other than insulin. Type 2 may, you can give oral agents. But patient, what will he do? Metformin, glibenclamide, pulihora. Bush, 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 bush. Then after half an hour, ఏంటండి ఏమన్నా తినండి. So, what is the common reason diabetes? Loving wife, good chef. She wants her husband to taste everything she made with rice. Right? So that makes husband slowly, unknowingly, will become mesomorphic. After that, he'll start enjoying being chubby at a point. After that, he'll get depression if he don't even look at rice. That's where. So, you can give oral hypoglycemic agents, but tell patient, diabetes is not a disease treated with tablets. It is treated by not eating rice, eating only 2 times, not eating wheat, eating chirudanyalu, eating more protein, eating less carb. That education is needed, right? So, gestational diabetes. Few people get glucose intolerance during pregnancy. Such people will end up later part of the life in diabetes. Then, what are the drugs that we give? How do they work in diabetes? Glitz, glins, glips, glyphs. Glitz, glins, glips, glyphs. They help to normalize the platelet function, pancreatic function. But before that, let us look at insulin. इंसुलिन में 4 तरफ की इंसुलिन होता है. अल्ट्रा शॉर्ट एक्टिंग, मीडियम एक्टिंग, लॉन्ग एक्टिंग, लॉन्गेस्ट एक्टिंग. Okay, so what is the story behind these various insulins? How many times? Ultra short, medium, long, longest. Each type, one type you know enough. Ultra short acting, aspart insulin, commonly we use in practice. Aspart insulin. Short acting is your regular insulin, which is rapid acting insulin. Extra rapid, regular insulin you give now. Regular insulin is short acting. Protamine insulin is medium acting. Glargine insulin is long acting. Degludec is very long acting. So whenever you give insulin, what is the challenge? The challenge is if its duration is more than what it is supposed to do, it will lead to hypoglycemia. That's the challenge, right? कोई बंधु हमारे घर को आया, वो आके काफी पी के गए तो अच्छी बात है, आते वक्त कुछ रिटर्न गिफ्ट भी वो लाए तो और अच्छी बात है। मगर वो आया, 3 दिन घर में ही रह गया। A boring job to have him like that. How can mother-in-law can stay so long? 3 days of the stupid mother-in-law, her principles, how she used to love in her days, how she used to look at her mother-in-law. Ha! We don't want mother-in-law to stay too long, right? So any insulin which stays beyond its invited time can lead to hypoglycemia. That's a problem. If you look at your regular insulin, actrapid, it works for 6 hours. If you look at protamine, it works for 12 hours. So what these two insulins are dangerous is, the moment you give insulin, it will go into peak, right? And it stays more than needed. So if I eat 2 laddus and take insulin, this insulin's peak has gone that it is needed for 10 laddus. Because of that, what happened to me? I only ate 2 laddus and took, and then this peak led to hypoglycemia. 6 hours. Then second is what? Medium size. I ate laddus now, 3 laddus, but I am doing puja and I don't want to eat for the next 12 hours. But this insulin which I took is staying for 12 hours. And it is demanding me to eat. If I don't eat, I will go into hypoglycemia. Hypoglycemia is the biggest risk with short acting and medium acting. Now, if the mother-in-law, instead of staying 3 days, what you will tell her? Such a loving mother-in-law you are. Come to America. Stay here for 3 months. All mother-in-laws will be afraid. Why? They will do babysitting there. When the daughter-in-law goes to work in California, it's the life worse than Negro. Right? You're a slave imported from India. If your daughter-in-law is very loving and calls, అత్తగారు మీరు రండి, అసలు మీరు అసలు రానే రండి కాలిఫోర్నియా, మీరు భలే రండి రండి అంటే, ఇంట్లో పనులు చేయండి, గార్డెనింగ్ చేయండి, నా కాళ్ళు కూడా వత్తండి నేను ఆఫీస్ నుంచి రాగానే. अंडरस्टैंड? सो बहुत 48-72 आवर्स अगर वो रहे तो इंसुलिन, इट्स लाइक mother-in-law coming to California to take care of your messed up family, right? When you go to work, it's good. And there is no sudden peak. Sudden peak is hypoglycemia. If she comes 3 days, she will tell how to wake up early morning, how to clean the home, how to iron the clothes of her son and all the stupid things, right? So, 3 days, dangerous. 48 hours, good. That's what our glargine, which is the long-acting, will do. So somebody said glargine is called peakless insulin. It does not peak. Slowly, like a mother-in-law, 6 months, he will deliver the service. Right? So it is good. Somebody said, why this mother-in-law 6 months? Let her permanently take a visa. परमानेंट सिटीजनशिप एंड स्टे. वो मर के दम तक मेरे ग्रैंड डॉटर को भी सर्विस करके मर जाएगा बुढ़ी. That is called as deglutic insulin. It works slowly up to 72 hours. It is altogether good, right? So then comes a unpredictable patient. एक दिन मूड आए तो वो 10 लड्डू खाता है, अनदर दिन मूड आए तो 20 क्या पुलारिटी स्वीट्स खाता. बहुत मुश्किल है उसको. तो इसको अगर इंसुलिन शॉर्ट एक्टिंग देना पड़ता, क्योंकि उसके मूड के बाद बेसिस पे इंसुलिन दे सकते, बराबर। बट प्रॉब्लम इज, इसको क्या है ना, 6 आवर्स वाला रैपिड एक्टिंग इंसुलिन दिए तो थोड़ा किडनी में भी खराबी है, इसलिए सडनली ग्लूकोज कैन फॉल एंड ही मे डाई। सो अल्ट्रा शॉर्ट एक्टिंग, आओ काम करो जाओ, आओ काम करो जाओ, कितने यूनिट्स देना, खाने के देने के पहले शुगर चेक करते, 200 के ऊपर है तो 10 यूनिट, 180 के ऊपर है तो 8 यूनिट्स, 160 to 180 है तो 6 यूनिट्स, 140 to 160 है तो 4 यूनिट्स, लेस देन 100 है तो नो यूनिट्स बोल के एक टेबल बनाया और दिया इसको एस्पार्ट इंसुलिन, ओनली 1.5 आवर काम करेगा और शुगर को नीचे लाएगा, चले जाएगा, इट्स गुड। So that also will not lead to hypoglycemia. So that is what you call aspart insulin. So tell me, aspart is ultra short acting, regular insulin is short acting, protamine zinc sulfate is medium acting, glargine is long acting, D-glutic is super long acting. Citizen, right? So that's all you need to know. Earlier days we used to give what, 30, 70, 50, 50. What is 30? 30 is rapid acting regular insulin. 70 is then zinc protamine medium acting. But there used to be still hypoglycemic effects because of that. So that is the reason always the best combination is what, night में glargine insulin, pen मिलता. Even grandma knows how to pick up the skin and take the shot. Glargine is 48 hours, which is long acting. Lantus बोल के आता है. Fiasp, asp means aspart. Fiasp is the insulin which is ultra short acting. According to the chart, you can give Fiasp insulin. Fasting, pre-lunch, pre-dinner. 3 values you ask them to record. Based on that, you decide 4 units, 6 units, 8 units, 10 units, depending upon. You tell them. 3 times लेना पड़ता है Fiasp. Then D-glutic, Tresiba is the brand which I commonly give. So this is 20 units, 10 units depending upon vazan. Normally any person require how much insulin? 1 unit per kg. And always if you did not check the weight of the person and giving insulin means you didn't go to med school, right? Always check the weight. So for example, your typical patient is 80 kgs. He require 80 units. 8 units may, let us say 20 units you gave as Tresiba, that is D-glutic insulin. D-glutic insulin. It will take care of next 72 hours slowly like our physiological one. Remaining how much he require? 60 more units. Let us say you have given Fiasp for him to take. Fiasp is aspart insulin, right? So he checked his sugars before breakfast, before lunch, before dinner. So before breakfast, he found that his sugar value, plasma sugar value, is 220. So how many units? Typical calculation, yaad rakhna. More than 180 means you can give 10 units per. More than 160 means you can give between 160 and 180. You can give 8 units. 140 to 160, 6 units. Right? 100 to 140, 4 units rakho. Below 100, nakko dena. Ultra short acting. So, wo kya kiya? 10 units, 220 है breakfast, before breakfast. क्योंकि कल रात को वो दावत को गए, अच्छा खाए और पिए, आइश किया, आया, सुबह को 20 यूनिट्स खाए, 220 बोल के उसको टेंशन में आ गया, जैसे 220 एंटी वाला 10, सो 10 दे दिया आपने। तो आफ्टरनून शुगर चेक किया और वो फील कर रहे 220 इज टू मच, लेट मी नॉट ईट एनीथिंग बोल के बैठ गया। शाम 4 बजे तक कुछ भी नहीं खाया, तो आप दोपहर को देखे तो उनका शुगर गिर गया 120 को। तो आप कितने देते थे? 100 to 140 मीन्स 4 यूनिट्स दिया। तो 120 में आ गया मैं बोल के रात को फिर दावत को गया। There are few people who are regular दावत इब्राहिम्स। दावत। सो नाइट को फिर गया दावत इब्राहिम ने, तो फिर बिरयानी खिलाया। वो लोग कुबुल कुबुल बोल रहे, ये तो कुबुल कुबुल बोल रहे। देवा नीकु स्तोत्रमु नाको आत्रमु। So he is eating. So what happened? Once more, next day, fasting became 240, 250. So like that, FIASP is decided by his fasting before lunch, before dinner, right? But Tresiba, same dose, it doesn't matter, every day. So after 5 days, you tell, this is my WhatsApp numbers, keep sending me your sugar values and your what you call, Dawatonomics. Your Dawat invitations will be jana. So that's a thing. So then what happened? You found that, this guy regularly is requiring 20 units of the gludec, and overall 3 times milai to aspirate insulin that he is requiring is about 30 units. That means his body is producing only 20 plus 30, 50 गए तो 80 kg आदमी है ना, 30 units only it is producing, right? Then what you can do, you can combine the two. You can combine what? Your digludec and aspat into one single injection, उसको बोलते हैं Rhizodec. That brand is called Rhizodec. Rhizodec में क्या रहता? Digludec रहता, aspat भी रहता, दोनों रहता। 30% will be aspat, which is ultra short acting, and 70% will be digludec. So you try to offer this only 2 times, morning and evening, so that his total requirement of 20 plus 30, 50 is being taken care by 2 times only. So first 1 week you keep for deciding the requirement of his exogenous insulin that need to be given. This is the way you manage diabetes. No rocket science. Understand? Even in hospital also you can do that. In hospital he got admitted also. So that Tresiba, that is digludec and aspartame, little costly compared to your regular insulin. Regular insulin 100 rupees hai to wo 300 rehta. That is one important thing. Second thing, always, unless you give metformin, insulin response will not be strong. That's the reason, even though you are giving insulin, you need to still give metformin. Metformin maximum you can give up to 2000 milligrams if we can tolerate. But 1500 mg commonly we give. Okay? Now, story over. You understood now? प्रिस्क्रिप्शन लिख रहा जाके, क्या है मिक्सटार्ट, क्या है ये प्रोटामैन इंसुलिन, क्या है वो सब छोड़ दो, डिग्लूडेक एस्पार्ट, ग्लार्जिन को भी छोड़ दो, डिग्लूडेक एस्पार्ट, फाइनली कॉम्बिनेशन ऑफ द टू इन राइजोडेक, बस. So now let us talk about the oral hypoglycemic agents. Classification: biguanides, thiazolidinediones, SGLT2 inhibitors, GLP-1 analogs, DPP-4 inhibitors, sulfonylureas, meglitinides. These are the जनरल क्लासिफिकेशन. मैं आता हूं, एक एक को पकड़ के खत्म करेंगे. Biguanide, what is that? Metformin is called biguanide. It is called euglycemic. Why? It does not lead to hypoglycemia. It does not lead to hypoglycemia. Whereas sulfonylureas दिए तो hypoglycemia जा सकते, मगर metformin दिए तो नहीं जाते, इसलिए it is euglycemic. It inhibits mitochondrial glycerol 3-phosphate dehydrogenase. याद है ये क्या है एंजाइम? बहुत सालों के पहले, 4 साल के पहले पढ़े ना. Glycerol 3-phosphate dehydrogenase. So that lead to inhibition of hepatic gluconeogenesis. Glucose become glucose 6-phosphate become fructose 6-phosphate become fructose 1,6-diphosphate become 1,3-diphosphoglycerate, and this become phosphoenol pyruvate become acetyl CoA will enter into citric acid cycle. So if this takes a reverse direction, you call it as gluconeogenesis. So glycerol 3-phosphate dehydrogenase glycolysis को आगे बढ़ाएगा. Inhibition will cause पीछे. Correct? No. Inhibition of hepatic gluconeogenesis occur if you inhibit the glycerol 3-phosphate dehydrogenase. Up homework. By glycerol 3-phosphate dehydrogenase inhibition caused by biguanides lead to inhibition of gluconeogenesis. Jara WhatsApp karna. Then another thing, what it will do? It will increase the insulin sensitivity. Main problem क्या है टाइप 2 डायबिटीज में? एडिपोस टिश्यूज के पास अगर इंसुलिन जाके ग्लूकोज अंदर जाओ बोले तो कोई बात नहीं सुन रहे. ये बाइगोनेड जाके इंसुलिन सेंसिटिविटी को बढ़ेगा. दैट्स द एडवांटेज. बट व्हाट इज द साइड इफेक्ट ऑफ मेटफॉर्मिन? कुछ लोगों को मेटफॉर्मिन दिए तो ब्लैक कलर्ड मोशंस, डायरिया शुरू हो जाता. 3 days 4 days डायरिया में जाता. वो आके पूछेगा, because of you I got diarrhea, I suffered, compensate me. That's the reason, tell the patient diarrhea can happen but I have no other option than to give you. Then you are safe. So biguanides can lead to diarrhea, and biguanides will lead to lactic acidosis. Because glucose become ultimately pyruvate will go into, has two choices. It can become acetyl CoA or it can become lactic acid. So the tendency for pyruvate to become lactic acid is increased. Not in all, only those who have renal dysfunction. Diabetic nephropathy है तो अगर आप metformin दिए तो chance of going into lactic acidosis will be there. So that you need to be careful. Then metformin lead to vitamin B12 deficiency. That's the reason always give methylcobalamin 500 micrograms. Mecobalamin tablet, methylcobalamin tablet milta 500 micrograms ka. So that you need to supplement. But advantage of metformin is it will lead to weight loss. Weight loss is good. Because of that, the adipose tissue will diminish, resistance to insulin will diminish, which is good for type 2 diabetes. So always oral diabetic drugs need to be looked at, which will cause weight loss, which will not cause weight loss. In fact, some drugs will cause weight gain. Why? Suppose if you take the drug if it stimulates the insulin, it's called insulin secretagogue. Insulin is what? Lipogenic hormone. Whenever you take insulin, insulin is a lipogenic. That means it will make acetyl-CoA become palmitoyl-CoA, become fatty acid, become triglyceride, become stored in the adipose tissue, become apple-like fat. So insulin is lipogenic. Those people who take insulin, they will have a little fat. Understand? So that is the reason, if your patient is thin or fat, if he is thin, emaciated, you can still give sulfonylurea like drug, which is an insulin secretagogue, which will make him fat. But he is already fat. If you give a drug like sulfonylurea, it will make him more fat, more resistant to insulin action. That's the reason metformin is good, because metformin leads to weight loss. Metformin inhibits hepatic gluconeogenesis. Metformin improves the insulin sensitivity to the tissues. Metformin can cause vitamin B12 deficiency. Metformin is a bicurate. Bus 5 points, 5 marks. So this is metformin. 500 milligram, 250 milligram, 750 milligram, 1000 milligram. All are available. That's the reason always start slow. 250 mg, then 500 mg, then tolerating means 500 mg twice daily. Still tolerating means 500 mg twice daily. Like that you can. Instead of patient suddenly getting diarrhea and then coming and fighting with you. Then comes thiazolidine diones, which are pioglitazone, rosiglitazone. So how do they function? We use a common brand called Pios, 15 milligrams, pioglitazone, right? You don't know any medicines, but please know diabetes medicines, BP medicines. ये दोनों आ गया तो आपके हाथ में अस्त्र मिल गया है, एक के बाद लोगों को मारते ही आगे बढ़ना, right? And if you don't know how to treat diabetes, hypertension, you feel emaciated before patients. Because patients will know better than you about metformin, types of insulins and all that is not good. Okay? So pioglitazone, 15 milligram, 30 milligram, like that. When I was doing MD, pioglitazones are hero medicines. No, now nobody is caring. I don't even write pioglitazones. Because pioglitazones can increase the risk of heart attack, MI. It can lead to congestive heart failure, especially rosiglitazone. And also, they will increase the risk of fractures, osteoporosis. That's the reason we are worried. And pioglitazones lead to weight gain. They lead to edema. And how do they function? Pioglitazones are called PPAR gamma, nuclear receptor activator. Because of that activation, they increase the insulin sensitivity. So in few people, when the insulin requirement is 100 units, 120 units also, sugars will not come down. Such people को insulin sensitivity को बढ़ाने के लिए, we used to add pioglitazone along with insulin, and along with that we also used to give metformin. But that strategy is no more used by many clinicians. So now you know what is pioglitazone, PPAR gamma activator. Next comes sulfonylureas. Pharmacology exam mein they say first generation, second generation, third generation. Only one sulfonylurea we remember. We need to remember. What is that? Glimepiride. Emeril, Zoril. Any ril is glimepiride. 1 milligram, 2 milligram, 3 milligram, etc., etc. But it is what? Third generation. So anyway, try to know the names. First generation is chloropropamide, tolbutamide, no more use even on enemies. Sulfonylurea second generation is glipizide, glyburide. Glipizide, glyburide. Few clinicians use that. Modern time is third generation, which is glimepiride. Okay? So, how do the sulfonylureas act? They go and close the potassium channel in the pancreatic B cell membrane. That will depolarize the membrane. Depolarization releases the insulin. One ion is sufficient to. Our life is nothing but inorganic chemistry. Sodium, potassium ions only. Calcium, magnesium will decide our life. Little extra potassium means cardiac arrest, dead. Little low sodium means we forget world, that we are in world also. Hyponatremia. So, it will go and close the potassium channel in the pancreatic beta cell membrane, and that depolarizes the cell and releases the insulin. Because insulin is lipogenic. If you give the sulfonylurea, what will happen to the person's weight? Weight gain. Earlier days, chloropropamide, tolbutamide days में ये लिए तो disulfiram like reaction used to occur, but nowadays it is not. Okay, so this is the common glimepiride. Few people use gliclazide, 30 milligram, 60 milligram, 80 milligram, gliclazide. That is all old process. Glimepiride. Even glimepiride also after gliptins came. Gliptins, I'll come to the gliptins. Glimepiride also few people use, but I don't prefer. Unnecessary weight gain, and these are known to be insulin secretagogue. Suddenly, oh, खाना नहीं खा के tablet लिए तो hypoglycemia bushu. Who will take care? है ना? Huh? So that's the reason. Then comes glins. Nati-glinide, repa-glinide. I don't use them. Only for textbook. What are they? Typically, they cause an increased release of insulin by increased calcium influx into beta cell membrane and release the insulin. But they lead to hypoglycemia, especially in renal failure patients. My nephrologist friend don't like that. Because if I kill the patient before his dialysis using hypoglycemia with nati-glinide, maza nahi hai na. But still few people use repa-glinide. It also releases insulin, na, isliye it is weight gain. So there's a cell wall. What will repa-glinide will do? Repa-glinide will cause ADP-dependent potassium channels close, that lead to depolarization, that lead to calcium influx, that lead to insulin secretion. That is the story behind repa-glinide. Then comes GLP-1 analogs. This also we don't use. But we read all this for entrance. This is for those celebrity doctors with celebrity patients. If you are practicing Banjara Hills, Jubilee Hills, you can use GLP-1 analog. Because there, I have 500 crores properties in the industries, doctor. But problem is I can't move my hands or anything also. I'm so fat, I don't know what to do. Then what will you use? Semaglutide you will try. Why? It will increase the glucose-induced insulin secretion. It decreases glucagon release. It will decrease the gastric emptying. It will also increase glucose-dependent insulin release. But it leads to weight loss. So that's the reason heavyweight champion patients are there, no? In them, you can try semaglutide, right? And it will increase satiety. Half idli only will make the patient feel like he finished a buffet. Right? So, GLP-1 analog is liraglutide, exenatide, semaglutide. These are all what GLP, glucagon-like peptide 1 analogs. So, whenever you eat food, glucagon-like peptide 1 become released and it will go and tell your brain that this buffalo is eating. Whereas if you take semaglutide, even without your eating only, GLP-1 analog will get released. It is an analog, no? It will go and tell brain, no. What he has eaten is a semaglutide tablet, not dozen idlis. Understand? So, some patients, I used to have one nice Dursani from Karimnagar. అన్నపూర్ణ గారు పేరుకి తగ్గట్టుగా ఉండేది. ఏంటో డాక్టర్ గారు, నేను ఎంత ఉపవాసం ఉన్నా కూడా ఈ బరువు తగ్గలేకపోతున్నాను, ఈ షుగర్ కంట్రోల్ కావట్లేదు. అవునా అమ్మా, మీరు ఉపవాసం ఉంటారా? అవును, ఉపవాసం ఉంటానండి డాక్టర్ గారు. ఏం చేస్తారు మా ఉపవాసం అంటే? అసలు ఎట్లా ఉండగలుగుతారు మీరు అట్లా అంటే? లేదు డాక్టర్ గారు, పొద్దున్నే ఒక 2 లీటర్ల పాలు, అందులోంచి ½ లీటర్ ముందు తాగేస్తాను. తాగిన తర్వాత 11 గంటలకి అరడజన్ అరటిపళ్ళు పూర్తి చేస్తాను. మధ్యాహ్నము, ఇన్ హర్ డెఫినిషన్ ఈటింగ్ ఫ్రూట్స్ ఈజ్ నాట్ పార్ట్ ఆఫ్ ఫాస్టింగ్. బకాసురులా తింటున్నాగా. I said, don't do fasting if you want to lose weight. Right? Satiety, doctor. Few people can't control that impulse. That's called bored eating. कुछ भी काम करने के लिए नहीं है तो खाओ. So that's called meeting for eating. Meeting for eating. That's okay. When you are young, you can do eating, then meeting, then eating, and then meeting. Anything you can do. But eating is an impulse. You are pushing something into that lumen of the tube called as gut. So GLP-1 analog will create the satiety and decrease the obsession for eating. Then what revolutionized the diabetes treatment and we use every day in and day out, doctor? Gliptins. It revolutionized. No risk of hypoglycemia, no risk of weight gain, wonderful control, very few side effects. Long-term HbA1c normalizes dramatically. Patient with 9 also will go into 6 if you use sitagliptin, vildagliptin, linagliptin. Gliptins have revolutionized. So how gliptins are used to control diabetes? They are called DPP4 inhibitors. What is DPP4? Whenever you eat food, right? Whenever you have a food intake, what will happen? There is a release of glucagon-like peptide 1 in response to the food is sitting in the digestive tract lumen. Then this GLP-1 will go and cause, GLP-1 is called incretin. It will go and cause release of insulin and inhibit the release of glucagon. But unfortunately, this GLP-1 is broken down by an enzyme called DPP4. So what they found, instead of giving GLP-1 analog, why don't we prevent its breakdown so that his own GLP-1 can bring quick satiety, also make his insulin naturally released, make his glucagon get stopped. So glucagon is anti-insulin. Glucagon will cause glucose intolerance. बोल के किसी को आइडिया आके एक आइडिया बदल दिया. ग्लिप्टिन को डिस्कवर किया. So accordingly you have sitagliptin, linagliptin, vildagliptin, etc., etc. And this is also weight neutral. It not cause weight loss nor weight gain. It will increase the satiety. So that is the beauty part of the gliptins. Understand, doc? So commonly we use 50 milligrams sitagliptin with 500 milligrams of metformin, istamet. Morning one, evening one tablet दे दो initially. 11 से 7 को नहीं आए तो पेशेंट को बोलो मैं इस्तीफा देता हूं एमडी के लिए. Patients will thank you profusely. Wow, what a doctor, right? And one advantage is क्या है, drugs which give satiety. You don't need to waste your time to tell him why to not eat like a monster. Naturally, drug only will make him to not feel like eating. All right? Then there's no difference between sitagliptin is better than vildagliptin. Only it depends upon the perfume of that medical rep is wearing. Good morning, sir. You can give vildagliptin, which is much better. Yeah, definitely. I'll be writing vildagliptin only. No need, right? Will all try your olfactory senses, your salivatory abilities to ultimately make you write their drug brand. All are same. Only advantage is those who have renal failure. For them, preferred gliptin is linagliptin. It is available as a brand called Linera. 1 minute. It's available as a brand called Linera, Lineris, many things. 5 milligrams. 5 milligram Linera de do. Better for those who have renal failure, morning ones. Otherwise, sitagliptin, vildagliptin are equally good. Then comes sodium glucose co-transporter 2 inhibitor. So fundamentally, if you look at your glomerulus, glucose enters. SGLT2 will cause the glucose reabsorption in proximal tubule. If you inhibit that, what it will lead to? Loss of glucose into urine. So when these SGLT2 inhibitors came into market, everybody said, wow, this is the drug. This is the drug we are all waiting for. But unfortunately, all that excess sugar inside the tubule will breed UTI. I have at least 1,000 cases of urosepsis of the people who have been treated with dapagliflozin 10 milligram, 5 milligram. But if the patient sugars are not coming down, no, in such people, dapagliflozin will zoom, bring the control. But too long using dapagliflozin, especially summer May, they don't drink water. Already urine concentrated and urine is going and they are more risk of developing UTI, urosepsis. So be careful, though it is a very good drug. Another thing, if the patient is fat, if he loses continuously glucose into urine, he will become thin. He will thank you. What a nice doctor you are. Yes, sir. I'm making you to lose urine, water, dehydrate, and you bloody 42-liter can of water is shrinking. He doesn't know. You got me? 60% of body weight is total body water. No. You are making all that glucose and water go into urine. Person shrinks every day down into Eddie Murphy movie, the Nutty Professor. He will become completely thin. Okay? So that is what you need to remember. So, vulvovaginal candidiasis, urinary tract infection, biggest problem because of the sugar lost in tons and tons. Their urine is like a sugar factory. It's like a sugar cane juice. Utna sugar खो जाता है. If you are using SGLT2 inhibitor, entrance में पूछता, is it SGLT1, SGLT2, SGLT3? It is not 1 or 3 or 4 or anything. It is only SGLT. मेरा नंबर आ गया एंट्रेंस में बोले तो 2 को याद रखना. Okay, so that is dapagliflozin. 10 milligram, 5 milligram tablet is there. Empagliflozin. Old timers use empagliflozin. Then comes acarbose and miglitol. What will they do? They'll go to the intestinal brush border. They inhibit alpha glucosidase. So at intestine level, they prevent carbohydrate reabsorption. So where do you use acarbose? I don't use acarbose. I hate it. Because few people may have a nice fasting sugar, 90, 95. But postprandial will be uncontrolled. This reason, postprandial hyperglycemia जिसको ज़्यादा है, उसको खाते के पहले अकारबोस ले लिए तो जो भी कार्ब है, that won't get absorbed. Hence, postprandial hyperglycemia can be better controlled by giving acarbose. But what is the side effect? Borborygmy. They will be like a bombing machine, right? Because that causes bloating of the, because carbohydrate which is not absorbed in the, staying in the gut will get fermented, gases released. He'll be AK-47 rifle. So that is the only thing. And there is also good, because of that discomfort, maybe he is a member of parliament or MLA, take acarbose that you gave and gone there. Adhyaksha, top. So, Adhyaksha, top. So what happened? He won't eat carbohydrate to avoid the discomfort. So few people who are not ready to listen to your dietary advice, for them only you use acarbose. Otherwise I don't use. Acarbose and miglitol. Finally, you have amylin analogs. They decrease gastric emptying, so that whatever you eat won't go into intestine and get absorbed, it stays in the stomach. Then decrease glucagon release. That is the function of amylin analogs like pramlintide. They will also increase satiety. Pramlintide is a amylin analog. So this is called simylin pen, pramlintide. इंडिया में उतना इजीली नहीं मिलता, तो थोड़ा अमेरिका से मंगा के वीआईपी पेशेंट्स को गुड टू यूज pramlintide injection, which is amylin analog. So a lot of patients come with a Google search about pramlintide and say, doctor, that costly treatment to lose the weight and good for diabetes, will you give it? If he can afford, simylin pen. Shanti, we are done with diabetes. Okay? Time entindi? Ammo. This is overtime. For 4,000 rupees, this is overtime. Right? Good. Thank you all for, after a long time, I took medicine marathon session just for you. Good luck for your medicine exam. And you know, when I have gone to medicine exam in 1996, just 1 week before medicine exam, I eloped with a girl who has 7 mamas. I came to RSMH married. They filed a case on me, and they all came with daggers and razors to catch hold and kill it, shoot at sight. I went in Kaktiya Medical College and stayed in a room. Of course, that girl is still my wife. Then I went to medicine exam. I was afraid what to do. Then I found a group of my classmates on the patient. इसको केस लीक हो गया क्या, मैंने सोचा. मैं कुछ भी नहीं पढ़ा, जस्ट गया एक्सटेम्पोर. क्या कर रहे हैं, ये केस है क्या, एग्जाम केस. No. We are thinking is they used to call me Harrison. So we are thinking that first time we listen, no, that is systolic or diastolic. Amma. With these classmates, I'm distinction. I thought, I thought it is distinction, right? And first case, second case, third guy gone. Examiner's questions are leaked. He only asked one thing: what do you use for congestive heart failure? And tell about what you call Parkinsonism drugs. 2, 3 points he is very good at. Instantly revised answers and gone and answered confidently and came out with the first course. So passing medicine exam is easy. So you don't need this much hard work. Did you require all that? No. ఇవి ఏం నిలవకుండానే పాస్ అయిపోయినాము అట్లనే పాస్ అవుతాము కాకపోతే ఇవి ఇప్పుడే తెలుసుకుంటే దిస్ నో రాకెట్ సైన్స్ ఆ 160 pages మాస్టర్ చేస్తే in that 160 pages you are having around 3400 points గడ మాస్టర్ చేయాలి రీజనింగ్ తోటి type 4 RTA is hyperkalemic but 1 and 2 is hypokalemic అట్లా చేస్తే కనుక smash examiner. Okay, so good luck for your time and let me know if you require surgery revision. Let me know, I'm always there, but 10 should come. You mobilize Shada and Deccan, Medicity everywhere. Okay, all right, thank you very much. So tomorrow evening onwards our crash course will begin. So where do you stay? Nearby only, no? So evening we'll try to start, and Ujjwala said morning is comfortable. 10 to 1, we'll see, and I'll give you 22,000 high yield facts ka notes, PYQs ka. वो revision करेंगे, Sundays को grand test करेंगे, right? And whenever you get time, please do come with all your duties, right?
Actually, I did not get those notes.
You?
I did not get those notes.
Which one? Medicine, medicine notes, I will ask them. 2 volumes or 2 volumes is not useful also. You got that 160 pages. Must. And you have Mubin to teach you anyway. What do you say? Same college, Malaredi. తక్కువ చదవాలి డేవిడ్సన్స్ గ్రాండ్ సన్స్ నోట్స్ యూ షుడ్ రీడ్ ఓకే సర్జరీ డిసైడ్ కరో యూ వాంట్ అంటే కొంచెము అదే ఎగ్జామ్స్ దగ్గర పడ్డాయి కదా అందుకోసమే కంప్లీట్ చేయండి ఎగ్జామ్ నాకు కుదిరితే కనుక ఎగ్జామ్కిను ప్రాక్టికల్స్కి ఎన్ని రోజులు డిఫరెన్స్ ఉంటుంది అంతే ఇమ్మీడియట్గా ఉంటుంది అదర్వైజ్ ఐ థాట్ ఆఫ్ షోయింగ్ సమ్ ఎగ్జామ్ కేసెస్ cardiovascular, neurology and also surgery cases, but it's okay. We'll once more catch up after your exam is over for entrance. Entrance ko stamp marenge, top rank, internship mein first attempt mein, that should be the goal. Okay, chalo, thank you. Any doubts are there, keep proposing. Any specific topics you want revision also, you tell in edi mana WhatsApp group lo. Whenever I get time. తీసారా? No. Lifetime friendship. Tomorrow you'll become top consultants and you're going to treat my specific reference to patients. Okay, so it's lifetime. I'll also be interacting. Any questions you have, you put it. Any topics you want specific revision, I'll take time to conduct a session for that. जब भी tension आता ना, suddenly last moment में hypertrophic pyloric stenosis, मेरे बस में नहीं हो रहे sir. Okay, 5 minutes में I'll revise that hypertrophic pyloric stenosis for you. there are these 4 or 5 topics, I just want a revision, बोल के उसमें on demand